Do I have a microphone here? Yes. Okay, good morning, colleagues. Thank you for coming in early today. It's 10 o'clock. I'm very happy that we've come in time, after on time. And we are here for Dr. Kwizera Arthur's PhD report. I want to check in if I have all my panelists. I can see internally as Dr. Chama and we are here. Nicholas, I am sorry, I'm going to mispronounce your name. It's not as easy as Benon, but can you hear me? Are you online, Nicholas?
Yes, I can hear you.
Excellent. Morning,
good
sir.
morning.
How are you? How is it going? It must be cold now.
It's 8 o'clock in Sweden. It's raining and it's 4 degrees.
I can imagine. Yeah. Nicholas, if this makes you well, my first time when I was doing my PhD, I learned that this small airport, what is it called? So, but the lady who came to pick me gave me her jacket because me had come with a sweater. I didn't know it was winter. So she gave me her jacket. It was so bad. Yeah. But we really thank you for joining us today. And we're here with Arthur, who has been doing his PhD for the last 5 years. He has been cooking a great meal, and we really look forward to listen to him. But I just want to make sure I have my full panel. Dr. Sengova, are you online? Willie? Maybe not yet. I'm going to call him. Dr. Andia? Oh. Okay, maybe they will join us in time. So we are going to start our meeting with a prayer by Kirabo. Can you pray for us?
That's Christ, we thank you for this day. We are so grateful for the gift of life. We pray for the Holy Spirit. We waited for this day. Here we come. Lord Jesus, grant us.
Amen. Thank you, Kirabo. And Kirabo is the gift, right? So even if I don't put to miss Kirabo, it's still okay. Thank you, Kirabo, for the prayer. So, colleagues, the defense is going to be as follows. We will give the candidate between 30 and 40 minutes, but Arthur, please, we've been doing a good job. Can we give you up to an hour? Feel free. Okay. So after the candidate presents to us, he's going to have an intellectual dispute with the opponent, and the time is not limited. Nicholas, usually we give an hour, 2 hours for your engagement with the candidate. So you feel free, you can take as much time as possible. We usually model the Karolinska way of doing things. We've been having a collaboration with the Karolinska Institute for the last 20 years. So most of our defenses are modeled onto that Karolinska record. So feel free and engage with the candidate after he presents. Then after that, I will give the internal examiners, Professor Chama, Professor Rodria, up to about 20 minutes each. And again, it's a bit depends. feel free to really extend it as far as you want. Then after that, I will open the session to the public, including myself and the other members here and online. After that, we shall go for a closed session. Now, in the closed session, we as the panelists are going to discuss the merits and demerits of the PhD, and we discuss whether the candidate deserves the PhD from Ontario University, and we shall do a score. Unfortunately, the external examiner is not allowed to score because he has already given his score and will have it. So in the internal discussion, only the internal examiners and the examination panel that give a score out of 10. Any score of 6 and above means that the candidate gets the PhD. So that's the procedure. So I don't know if there's any question for clarification from the panel. Other than that, I really want to ask the candidate to present his defense. After Kwizera, you're welcome.
Thank you very much, Chair. Thank you, everybody, for coming. It's an honor to be here. The work I'm sharing is about acute hypoxemic respiratory failure in Uganda, the prevalence, outcomes, and the effect of respiratory interventions to improve those outcomes. My work is based on the fact that my specialty from the Department of Anesthesia and Care, my specialty is anesthesia, with almost all of it being intensive care. One of the challenges that we have in the ICU is obviously the resource limitations that I'm going to share. And the focus of what I want to do in my career is on organ dysfunction management, looking at frugal interventions for making sure that our patients recover quicker and cost effectively, whether with or without the ICU. So I decided to focus on the #1 reason for admission to the ICU globally, which is acute hypoxemic respiratory failure. And I know that we are coming from a COVID situation, a pandemic, and I guess in some respects it makes my work a little easier because each of us were affected by that in different ways. So this being a public defense, I will try to also break down some definitions. We have a lot of people who are non-clinical, and acute hypoxemic respiratory failure is the inability of the lungs to oxygenate. And as we know, as we learned from COVID, any inflammation of your lungs that's caused by mostly microbial organisms such as bacteria, viruses, some parasites, or any other aspect that affects the air sacs, as we call them, to move oxygen into the bloodstream and then to the heart and then to the rest of the body where it's needed. In many cases, initially does not present until a certain portion of the lungs is affected. So we have varying degrees of lower respiratory tract infections, and the more severe forms mean that a lot more lung capacity is impaired, the inability to supply oxygen to the rest of the body. And the most severe form is what we call acute respiratory distress syndrome. And in this situation is where almost 90% of our people need mechanical ventilation. And so a lot of this work is bordering on trying to see the best way possible to improve these outcomes, especially in a setting with resource-intensive, with limited resources. I'm sure even during the COVID pandemic, high-income countries also had challenges with mechanical ventilation of COVID patients. So the problem, this work has been probably the first of its kind in Africa to try and break this down as best as possible and trying to understand what we call the epidemiology. And the epidemiology ranges from causes and all the associated factors with this illness, how do patients fare through their illnesses from the onset of it, and also the long-term aspects of care. A lot of the research has been coming from high-income countries, and it's very difficult to replicate some of these findings or some of their recommendations in our setting where we have resource limited, we have infrastructure problems, as well as diagnosis. And because of this shortage, until this time, or data, it was very hard for our policymakers, Ministry of Health, and other places to come up with strategies for the management of this. We know that at least data from high-income countries showed that ICU admission, the number one reason, at least in our settings, patients need respiratory support, mostly of the advanced kind. Each and this law usually have less than 2 weeks. You might start with a cough or fever, and then what we call low levels of oxygen saturation in your bloodstream, commonly measured by what we call a pulse oximeter. And previously, they have most of the causes of the acute hypoxemic respiratory failure have been infectious. And we know from global data that mortality is high, especially in patients who need mechanical ventilation. Now, they in time to have been trying to assess the severity of hypoxemia, what we call, how badly low the oxygen is in your bloodstream. The gold standard is what we call a blood gas machine, and a certain ratio is calculated that enables us to determine how severe the illness is. Now, in Africa, previous data shows us now, especially from lessons during COVID pandemic, that of the patients that needed mechanical ventilation or advanced respiratory support, almost 50% did not get admitted. Now, this study was done in settings that had access to intensive care and had intensive care. So you have a hospital, then ICU, but it was almost always overwhelmed by the patients who had COVID. Now, what does this say about facilities, not referral hospitals, facilities that do not have access to intensive care? In our own setting, Dr. Jumanya and colleagues looked and found that we only have 1.3 ICU beds per 1 million population. And almost always the reason for admission was the need for respiratory support. Of course, the number one common causes included common things like traumatic brain injuries or infectious pneumonia. And this hasn't changed very much to date. Now, the other challenge is that even when it came to our healthcare leadership, a lot of research focuses on diseases rather than organ dysfunction. So the reason someone comes to you admitted, they have symptoms that are driven by physiologic derangements that are caused by the insults. So you see a lot of research in pneumonia that are caused by infectious disease, but almost none on respiratory failure, which is the organ dysfunction that invariably leads the person to hospital and the need for oxygen therapy on top of the management. So much so that even our Uganda clinical guidelines did not have any sort of recourse to advanced oxygen therapy for infectious pneumonia causes. So we really needed to look into this, find a way that can help inform policy as well as treatment guidelines in our healthcare system. So I was privileged to be part of the Uganda Oxygen Task Force, and I was in charge of this process. One of the things that we needed to do was to understand what the public knew about hypoxemia management. This was just to help us prepare the country for the COVID pandemic. And so at that time, found that only 40% of the facility had the recommended number of pulse oximeters. I prepared a decent number of them were functional. And then because of the COVID response, there was almost a fold increase in the number of pulse oximeters. The one key thing where the gold standard for blood gas for measurement of severity of hypoxemia, we found that none of the blood gas machines that had been supplied were functional. The biggest problem means that the gold standard for the diagnosis of acute respiratory distress syndrome or even severity of hypoxemia, because you then are able to make triage and treatment decisions, is that does not exist. This image just illustrates the different types of blood gas machine. Each machine can go for between 15 to 25,000 US dollars, and a test can range between 5 to even $25. A patient will typically need 4 to 5 tests per day. So the resource limitations that we have mean it will be very difficult to even sustain this. So our colleagues in Kigali came up with what we call the Kigali modification of the Berlin definition. The Berlin definition was a consensus speaking, trying to stratify the severity of lung disease. And other authors had already done in the lab some correlations between what we call the SF ratio and the PF ratio. Essentially, the SF ratio means that you don't need a blood gas. We'll take your pulse oximeter reading, and then we'll compare it with any oxygen that we're giving you. We call that FiO2. I'll explain that later. And if all the different devices have a controlled way or almost reliable, completely reliable way of giving you the F side, so that when you're able to calculate this ratio, you can then tell how severely your patient is. One common theme is, if you have a pulse oximeter, you have 2 patients who come in a similar condition. Both patients have, 90% on room air. The real severity of illness in the lung is not similar, just because the reading is similar. And the ratio was one step closer in trying to understand the severity. And by categorizing the severity, you're then able to make triage and different decisions. So pulse oximeters are obviously much cheaper than blood gas analyzers. We just need to use them a little smarter. So each of the oxygen delivery systems that is shown here, as you can see, they give a range, an FiO2 range. And we found that in the system, even during this initial evaluation, that people do not know about this. So the aims of this doctoral study was to assess, one, understand the epidemiology, which hypoxemic respiratory failure in our hospitals, then to try and help improve the diagnosis of ARDS using a low-cost solution, and then explore cost-effective non-invasive respiratory strategies, such as high flow, nasal cannula, and continuous positive airway pressure, to see if we can reduce negative outcomes. So this conceptual framework basically shows us at the interplay between the risk factors for development of acute hypoxemic respiratory failure, the modifiers that we have in our setting, and then of course progression from acute hypoxemic respiratory failure to ARDS and either survival or death, which is also affected by whatever respiratory management strategies that we provide, as well as the complications associated with these strategies, especially in a setting where you have a lot of mechanical ventilation. It's a very invasive tool, and the associated conditions are deleterious to them. So we wanted to see prevalence and factors, outcomes of acute hypoxemic respiratory failure amongst critically ill patients who are presented to Uganda hospital emergency departments. And we thought that based on data from abroad and other anecdotal experiences, that we might have a problem in this area. And then we wanted to see the incidence and outcomes of ARDS as defined by the Kigali modification using the SF ratio amongst critically ill patients in our ICUs, and also to understand how well they actually apply the diagnosis. And then, of course, we wanted to see if feasibility of these non-invasive respiratory strategies on survival outcomes can actually be applied in our setting, not just on the outcomes, but also because these devices tend to be used in ICU, HDU setting. We wanted to see if our lower level health cadres can be trained to apply them. So very specifically, we wanted to determine prevalence of AHRF and associated factors amongst critical ill patients presenting to departments, and then also to understand the in-hospital and 90-day mortality in the same patients in the departments, but also the factors associated with mortality. Sorry, I didn't write that down. And then the prevalence of ARDS and associated outcome using the validated modification of the Berlin definition, and then the assess the feasibility and effect of implementation of non-invasive strategies on negative outcomes amongst adult patients presenting with acute hypoxemic respiratory failure compared with conventional oxygen therapy. So that is low flow oxygen therapies in these departments. So the significance of this work was that one would help understand the burden of this condition, this setting, and of course provide for the first time evidence of the emergent feasibility treatment strategies in our healthcare system. The absence of evidence-based resources it makes it harder for us to make decisions for that impact our healthcare system's ability to treat acute hypoxemic respiratory failure. And I guess because during COVID, the global demand for ICUs, ventilators, human resources, and oxygen highlighted the gaps overall in other places, but hope that this study will use implement strategies to better treat HRF and ARDS in Uganda. So there were for the objectives, there were about I did 5 studies. The first study was a single center study, and we did this at Malago Hospital. Sample size was 327 patients actually, and the key outcomes were just prevalence, 28-day mortality, and then some key factors. We just wanted to understand, give us the first signal as to what might be out there. And then the second would be the prospective observational multi-center cohort study at 11 public hospitals. We had 682 patients and wanted to see if the countrywide prevalence and survival outcomes mirrored what we had in our single center and the factors which were associated with mortality. And then in 6 intensive care units, we did a prospective multi-center, and we were trying to see the one revalidate this diagnosis to look at the incidence of ARDS in this setting, as well as the mortality factors. We then did a prospective observational multi-center cohort in 13 hospitals around the country. And this was focused in COVID after we had done trainings with the Ministry of Health to help them improve respiratory management. So both using the SF ratio and also using the different devices. And then we summarize this, some of these lessons with a multi-center randomized clinical trial at 17 hospitals, where we enrolled 705 patients. So statistically, for across the board, depending on the paper, these were the statistical methods we applied. All participants had baseline data summarized for them, and then we used some of the classic statistical methods, reporting continuous measures with mean standard deviations or medians and categorical dichotomous variables as a factor of percentage of the sample size. We analyze mortality outcomes, time to event methods, appropriate for censored data, including Kaplan-Meier curves, and mixed effect Cox proportion hazard models where applicable. And then did standard mixed effect regression for binary outcomes and linear, mixed linear for continuous endpoints as per classic. And then of course we did multi-variable adjusted models for confounders. For the trial, I'll explain what we did. It was because it was a cluster randomized trial, the statistics were a bit different. I'll report them again. So essentially, the work plan in trying to understand all this is a single center gave us a signal. And then a year later, we picked some of these confounders, some of the variables we had learned from the single center to do a multi-center trial. And this was within the setting of COVID. Now, in that period, because of our involvement with COVID, and some of us were here, we were training health workers management. we help improve the care for these patients. The multi-center ICU, like I explained, looked at area prevalence practices, and then the multi-center COVID ICU units now, after introducing the high flow therapy, including procurement, mechanical ventilator for the national COVID response, was now to see how people applied respiratory techniques, how they understood, and also we looked at the outcome. We used that lesson to help us form the trial design for the fifth study. So the ethical considerations of this PhD work was approved by the School of Biomedical Sciences, High Research and its committee, and the National Council for Science and Technology. They approved the whole protocol. All the other ethical considerations were provided, brought administrative clearances for the involved hospitals, and then a waiver of de-identified chat inspections due to reduce participant research risk and COVID infection hazards for the study. For the fifth study, we got deferred consent for those who are critically ill, and the trial was registered on trials with the protocol that was published and shared. So, coming to the studies, first study, we conducted it at Lago. It was a prospective observational period prevalence study, and the findings were basically, we were tracing just the prevalence and outcomes, and then some of the factors associated with mortality. So we wanted it to be a primer for the next work. So in this study, as a period prevalence, I hope you can see the slides, we screened 7,300 critically ill patients with a score with a Muse score. Now the Muse is a sickness score, and typically any person who has a Muse of 4 to 5 would typically require at least emergency care, high dependency, or even intensive care. Now we had 327 patients that we analyzed. So the key findings were that the prevalence of acute hypoxemic respiratory failure was 4.5%. The median age was 3.8%. Now this age has gone up a little. 2012, when we published our first study with Dr. Nachibuka, the average age was about 27, and the median was just around there. So the most common cause was infectious pneumonia. For those who remember, the 3BM medical side of casualty was where we collected the data. We did the study. And as some of you know, the co-infection with HIV was a significant number of the participants. The key thing that we noted was, only 6% of the participants were admitted to ICU, and in-hospital mortality was 77%. At 90 days, it became 85%. So it was unusually high mortality. And that worried us a little bit, but it also helped us understand what the direction that we needed to go to. So because it was infectious pneumonia, of course, a high lung injury prediction score, HIV positive status, and then of course, some of the other markers of critical illness like anemia and thrombocytopenia were related to, were significant related to 90-day mortality. And that might be because of a number of things, HIV co-infection, the Q1, as well as maybe delayed presentation. So we had this study published in one of the DMJ Respiratory Journal, and it provided the first direct evidence, the burden of acute hypoxemic respiratory failure and why. And of course, anecdotally, one of the things we realized for those who knew 3D medical, we didn't have any standard way measure of assessing severity of hypoxemia. Resources were too few, and oxygen was not judiciously used to pick up effect oxygen systems, and so on. So we had some sort of guidance where we want to take this next. So the second study, now getting informed by what the finding in the first study, this happened to be in the time of COVID. We had, with the work that we're doing with an oxygen task force, procured quite a number of resources for oxygen therapy. And it was mostly for low flow oxygen therapy. As I showed with the face masks and the medical timing, which things were not very apparent in the first study. So we wanted to know the findings of the first study. What will change? One, if we do multi-center, would it be better? And also we want to now look at, as these people present, what are the factors associated with negative outcomes. Sorry, I've shared the publication, but the map shows you where we did the study. We tried to do it around the country as much as possible so that we are able to have some sort of generalizability in our healthcare system that will strongly inform evidence and military policy. So the prevalence was quite similar. About 4.1% of utilized patients had acute hypoxemic respiratory failure. Median age was a little older, was actually quite older, and again, males predominated. Of course, at that time, about 30% of the patients had COVID, and again, lower respiratory infections were the leading causes. And in-hospital mortality was now a little lower. And then, of course, the biggest challenge, we don't know why, but because a lot of resources went towards COVID treatment, we suspect that perhaps some people might have stayed home, either out of fear of COVID infection or hospital-related issues. The key things, again, admission to any ICU setting, even if we have tried to improve, only about 5.6% were admitted to the ICU. And the key things that we discovered, some of the differences in terms of mortality, were that people who are older, first of all, for AHI development, older, having a lung injury prediction score, which again we confirmed from the first paper, having a CAP 65 score of 3 or more, having COVID pneumonia, and having one NCD at admission. And NCD is a non-communicable disease such as diabetes, hypertension, non-communicable meaning non-infectious. So for the first time, we had some sort of direct evidence that non-communicable diseases can be a risk factor. We don't know why, we don't understand the mechanisms. That can be future work for anyone with this. From then on, we then moved to the third study where we were trying to look at understanding the validation aspects of the ARDS in this setting. We looked at practices. Do clinicians in these ICUs use this? Do they have the blood gases to help with this diagnosis? And the other thing was what were going to be the mortality differences in patients in whom had the diagnosis of ARDS as given by the clinicians, or and the diagnosis of ARDS driven by this the validation method that we use. So the key finding is we studied 312 patients. Of these, 231 were involved. Again, because a lot of these ICUs were more in the peri-urban areas, we noticed that traumatic brain injury and post-operative also dominated the reasons for admission. So technically, you maybe call these ICUs more surgical. But patients with acute hypoxemic respiratory failure also accounted for a good number. The key finding in this was 70% of patients who are on mechanical ventilation with these ICUs met criteria for ARDS as per the 25 days. But only 17% had an ARDS diagnosis done by ICU clinician. We put this down to mostly the lack of blood gases, but we also possibly the lack of ARDS management protocols in this setting. If you look at the flow chart, you can see a very significant number of let me see. Can you point out? The patients who met criteria had a very obviously had a patient much higher mortality overall. 35% of patients in this cohort died, but a very significant number of them had ARDS. So of course the question led us to think about the possibility of with ARDS, there's practices that we tend to be different in terms of management of their respiratory support. One being that we tend to be more frugal with the pressures that we dial into the ventilators. We tend to use more adjuvant therapies like perhaps the use of steroids. Some people might disagree, but also things like cloning position and also restrictive fluid therapies. Because once you have, you show that this patient has very diseased lungs. Diseased lungs are typically infectious. The ARDS lungs are typically wet. If you give too much fluid to that patient, you're going to more or less drown them because they are also very highly permeable. So you can get a lot of lung-related. The key things that we also noticed is that there was the hypoxemia in terms of using the SF ratio that we employed. The more likely you were to die. And again, we also found this big statistics significant. All along, there was nothing else that was after multivariate adjustment that showed up anything untoward with regards to all the other variables. So our patients, one, were younger than typical global cohorts. Two, the ICU did not use blood gases, or if they had them, they did not tailor them to mechanical ventilation therapy. And of course, I think largely we discovered that the SF ratio was applicable and it helped us identify sicker patients. So this study was the one in which we actively helped deploy, and this was during COVID. And this time we said, okay, the Ministry of Health has provided all these respiratory therapies, mechanical ventilators. This was all over the place. And because we were participating in some of the co-authors, this work as well as others, the ministry in oxygen management, we then introduced the concept of advanced respiratory therapies using non-invasive ventilation therapy like CPAP, as well as high flow nasocannula oxygen therapy. And we're also teaching them about the SF pressure in this regard. And we then just let them loose. We chose COVID. One, it was the most prevalent time of all infectious lung diseases. It was, I won't say, there was a little more control in terms of, we had designed a protocol and everyone was trying to follow the protocol. And we also decided to enroll patients who were really sick. So using the SF ratio, anyone who had a ratio of 315 and below, so that was what we called COVID ARDS. And when we then analyzed, conducted this study. The publication is also attached. But one of the key findings was the SF ratio was quite well used. We included a fair number of COVID-related ARDS cases, and we were able to identify, because we didn't interfere, this being an observational study, how the decision-making process was done in terms of providing respiratory support. Overall, many patients died, as we know, about 50%, and mechanically ventilated patients had the highest mortality, almost more than 80%. Obviously, we haven't broken this down by center, because this was something that we wanted to look at as a national thing. And then patients in high flow, who got high flow, had the lowest outcomes, followed by patients with CPAP. Now, this schema shows us at the first line the respiratory support strategies at admission, and then the second line shows us how clinicians decided to change course of as you see, of course, this being an observational study, we can only make very weak inferences. But one of the things we noticed that when patients received a change of a respiratory strategy, they tended to fare worse. Now, one big thing is in the change of respiratory strategy. A lot of those that change, whether it was from standard oxygen, high flow, CPAP, NIV, or LV. Standard oxygen is the low flow oxygen by face mask vasochromes. High flow is the more advanced non-invasive respiratory support, along with CPAP and NIV, which is non-invasive ventilation that uses two changing pressures depending on your inspiration and expiration, typically given by a machine. Same as mechanical ventilation, which is done in ICU. So on top of noticing the change in strategy, almost all patients who escalated to mechanical ventilation fared worse than patients who changed to any other modality. And in fact, most patients who change to any other modality in many of these other therapies, there was no change, one, and two, it just told us that we were much sicker that needed mechanical ventilation, and it gave us a signal that patients who received the non-invasive respiratory strategy tended to fare better. This was not a clinical trial, so it couldn't make very big claims. There was better association. And then patients who received proning, I've shared a Kaplan-Meier curve. Patients who were proned also tended to do better. So we realized for the first time also that there was more judicious use of oxygen. People are titrating better, and so the training that we instituted gave us relatively better outcomes. And a lot of this informed our decision for the last study. So after this, we had some signals of what therapies that we can use to improve patient outcomes outside of the ICU setting. But we didn't know at this time what kind of patients would actually benefit from these therapies. So we then did a multi-center cluster randomized step-weight clinical trial. And one of the challenges, one of the reasons why we chose this trial was for ethical concerns following some of the issues that had been identified during the post-trial. The issue was the hypothesis that you think that this is better. Why are you denying another patients what you think is better? So with this classroom step-weight trial, we were able to avoid some of the challenges. So we conducted this study at 17 public hospitals in Uganda, and we published the protocol. The study is currently under review. I will call the study Arise Up. So just to break down a little bit, the two non-invasive respiratory strategies that we chose were high flow nasocannula oxygen, and then what we call the Kwizera CPAP system. Most CPAP is generally given by machines, but knowing the challenges of the electricity with access to oxygen, we wanted to use a system that did not need any of that. And so we were able to, the Kwizera system is a system that has a very clever interface. It runs on the turbine principle and can deliver pressures of up to 15 centimeters of water. The high flow nasocannula oxygen gives humidifies air and can give 100%. Both can give 100% FiO2, and we were able to, and we're now available in the country. So this was the protocol that we used. So if a patient, first of all, we had two levels of randomization for this trial. There was randomization according to cluster, I will show that. And then there was also patient-level randomization. So we then decided, based on the lessons we have learned from the whole study, to now this time guide more the protocol, how to all the settings for the patients, all the way up to as per the study criteria. So the step-weight design First of all, we screened 20,000 patients at 17 hospitals, and then 97% of these patients were not in ICU. And the other thing that we wanted to see was whether medical officers and nurses with little or no prior critical care experience, if they are trained, if they can actually apply this, because this would be the first of its kind in the world to do this. So the cluster randomized, we had 8 clusters, and then we had 9 study periods. So all sites started with a standard for low flow oxygen, and of course patients were all randomized to low flow oxygen. After a period of 4 to 6 weeks, we then randomized one cluster. One cluster might have had 1 or 3 hospitals, and then at a patient level, we then randomized patients 1-to-1 to receive either high flow nasal cannula or CPAP. And by the end of the period, all sites, all clusters were now giving this. And at that time, that the IRB felt that this was probably a more ethical way to conduct this trial. So this is a study flow chart. Out of 20,000 patients who were assessed for eligibility, we ended up randomizing 701, and we with an intention to treat analysis, but also a protocol analysis where it mattered. At the end of the trial, we had 303 in the standard oxygen arm, and then 308 in the intervention arm, which had either high flow nasal cannula or CPAP. So just this, I've obtained this with consent. Just give you a sense of an idea of intimate. So the patient below is the Bosniak CPAP system, and you can see there is no connection whatsoever to electricity. So straight from the source of oxygen to the patient, and these were patients who are very severely ill and would have needed mechanical ventilation. The patient at the top was receiving high flow nasal cannula, and this one, yes, needs electricity, but also provided humidified air to the patient at a peak of at least 4 to 5. Both patients survived, but this was for illustration one. So the results, the preliminary results we have now, being that there's a slight embargo and this is under review, I had to get permission to share some of this data. The overall mortality in this setting was 33%, which was lower than some of the previous studies. In patients with refractory hypoxemia, that's hypoxemia that does not respond to low flow oxygen, or hypoxemia that is prolonged, that high flow nasal cannula was superior to all the others. But there was no significant difference between the groups. Chronic, even though we are trained, was more common in standard oxygen therapy arm, and IV fluids were given more in the intervention arm. Now, one of the things we noticed was trying to explain why the standard oxygen. Remember that in the intervention arm, as time went, more patients got randomized to that arm. However, when we started the trial, this was during the dry season, and we noticed that one, recruitment rate was a bit low, and patients who met criteria and indeed came, their SF ratios were lower. And towards the end of the trial, once the rain started, patients came in who were much sicker, and we attributed that to some of the challenges that we have in our healthcare system in terms of access and, of course, delayed presentation. And because they were sicker, this was a pragmatic trial. Because they were sicker, the admitting clinicians who were not part of the study tended to give more IV fluids, more therapy. Because they were sicker, they tended also to be slightly more hypotensive. And so that is why we noticed that the intravenous pressure didn't go in the intervention group. But we, in hindsight, we thought that the cluster randomized aspect would have helped with that. In the subgroup, we could see that in certain patients, especially, although this was not powered, patients who started the intervention, whether they were CPAP or high flow, tended to have a quicker resolution of their SpO2 or SF rate. This trial, the intervention was provided for only 7 days, and then patients were then stepped down pragmatically. But if they still needed the therapy, then that therapy was provided. But we wanted to look at the initial 7-day effects of this. So, so from this work, we found that high flow nasal showed signals for improved survival first in the COVID-19 cohort compared to CPAP and ventilation. In the clinical trial, the CPAP patients had the highest mortality, although we bunched them in the intervention arm. And then high flow nasal was the lowest for respiratory hypoxemia. Warning was beneficial, but was done more in standards. I have discussed the challenges of seasonal illness severity, how to practice outcomes. The key take here was that high flow nasal has a place. CPAP, the intervention has a place for patients who are either mild or moderate, but clearly not for those who are severe. So it has the benefit would be in reducing the need for mechanical ventilation. And I also shared that of those, that about in our study population, 32% of patients met criteria for intubation, but only 3% obtained any sort of. There's a lot more subgroup analysis going on. So the overall aspects from this body of work is that the incidence of acute hypoxemic respiratory failure in our setting is comparable to previous single center studies. But we know that now infectious diseases are the most common cause, upwards of 70 to 80%. The high 28-day mortality is likely due to the severity of disease presentation based on the seasonal variations that we saw, but also the aspect of delayed presentation because of terrain and also possibly those limitations. The limited access, obviously, to mechanical ventilation means that perhaps if we would have saved more, but we were not able to. We also saw that the presence of at least one non-communicable disease significantly increased the risk of health. We know that this low-cost diagnostic tool, SF ratio, was effective for stratifying the severity of hypoxemia and identifying patients with ARDS and high mortality. And that non-invasive advanced respiratory strategies reduce refractory hypoxemia and could be used by lower cardiac health workers. So the recommendations, one, to practice, strengthen the diagnosis of ARDS and severity of hypoxemia, to integrate chronic and non-invasive respiratory clinical guidelines in our health facilities. To policy, we found that at some point oxygen was not very well distributed across the facilities, and in some instances, the trial had to fund refilling of oxygen cylinders. And so we've come up with a suggestion on better track on which NMS has actually deployed, where they now are able to track facility transportation and refilling of oxygen. Then updating various curricula at health training facilities for improving hypoxemia management now that we have some evidence, and expanding access, procurement of more high flow mesocannular equipment, as well as the using CPAP devices for areas with no electricity. To research, I think because we are getting to the era of precision medicine, where we need to now start doing picking up phenotypes. And I hope from this data we may be able to pick some signals what type of patients respond to which therapy. And maybe we were thinking, okay, because we did not have the obstetric population, we know that critically ill mothers need intensive care, respiratory support, children, and other vulnerable populations may benefit from an adaptive Bayesian clinical trial with well-powered sample analysis. So this journey, I've had the benefit of using a lot of our work and findings to help us inform policy, mostly the low-hanging fruit. We're happy that the NMS finally agreed to include some of these non-invasive respiratory therapies into the new plan for national scale-up. I happen to be the lead for this project, and we give a lot of the evidence we generated contributed to all of this. We have also started to do this in lower level health facilities. So these findings are helping us look at the efficacy of and the ability. Now that we know that medical officers can use these devices, can they use them at the district level so that it helps the referral process as well as judicious oxygen therapy. We've had some success stories, new TB patients coming in with life-threatening hypoxemic respiratory failure, and they end up getting a chance and surviving. So during this journey, I attended some of the courses. There were the core courses required by the university. I also had the opportunity to spend 6 months in Italy doing advanced respiratory failure, endobronchial lung ultrasounds, and bronchoscopies, and all the other procedures. And then advanced research methodology, one here and one in Tanzania. We were lucky to get funding support for this one. One of the things that we're learning to do is networking with our colleagues from the rest of Africa to try and share the journey that we've taken in doing this research, because Uganda is not dissimilar from other African countries. We have been able to design an app that can help us identify sources for oxygen therapy, and our privileged to become founding chair of this critical care trials network that we hosted in Kigali. The ARISE been invited to present our findings, this being the first trial of its kind in Africa. Present our findings later this year in Australia. So the postdoctoral plans, well, to continue this one, and both as a clinician, as an academic, and hopefully to build more collaborations across the world. I want to thank our patients who have helped us generate this information, and hopefully pray that the evidence that will help us generate help improve their care. My supervisors and doctoral committee, the chair of the department, the ARISE network, who we work with to do a lot of this work, both the foundational work, my department and the College of Health Sciences, many of whom have been supportive and helping me write this, guide me, either being the doctoral committee or not. I was a Thrive Fellow, and I want to thank Kwizera and Harriet for being patient with me as I did this journey. And then, of course, you can't do a lot of this without family and friends. I thank you.
Thank you very much, Alpha. Ladies and gentlemen, allow me now to introduce to you my examination family. I didn't introduce it at the beginning because we were very much. I was very keen about time. Our external examiner from Sweden, and the Sweden time. I'll tell you a story. One day we had a lecture, at 11, and let's meet after lunch. being in Uganda, I came at 2 p.m. When I entered the door, they were going up and like, what's happening? Probably not coming. We are done with the day. Like, what do you mean? For them, lunchtime is between 11 and 12. Okay. So I was very keen that we start on time. But today, I'm happy to tell you that now I have my panel fully constituted. They were only 2 minutes late, sorry. This is everything. So my examination panel consists of a professor of anesthesiology and intensive care, Department of Clinical Sciences, Lund University in Uganda. And I also have a professor of medicine, William Ward, Professor Ochama from medicine, and internal examiner. I also have part of the examination panel. I have Dr. Paul Katongole. I hope you're online. You can hear me from the Department of Medical Microbiology. He is an IPC specialist. I also have Associate Professor Irene Andia, School of Medicine. And my name is Benon Asimon. I'm a professor and head of the Department of Medical Microbiology. I'm also the Deputy Dean for Research for and my dean is completed, he is the supervisor to the student, so you can share the meeting. I am now opening the meeting to the external examiner, Professor Nicholas Nielsen. Can you hear us?
Thank you so much. Is it time for me to start now?
Please, yes.
Yeah. And you can hear me all right?
Yes, we do. Go ahead.
Yeah. Thank you so much. It's a great honor for me to have been invited to be an opponent Makerere University in Kampala. And I wish I could have attended physically, and hopefully I can come another time. But it's if it works over video, that's great. I'm very honored to have been invited, even though I'm not an expert in respiratory medicine or respiratory critical care medicine. I can just say that my background is a general intensivist, so I worked a lot with these patients for the last 27 years. But my research focus is cardiac arrest and neurocritical care. And there might be some overlap there, but I think the PhD candidate, Arthur Kwizera, is probably more well known into the respiratory field. But I think we can have a good discussion anyway, and I will try to have a general overview and discuss some research methodology. And first, I would just like to see that I have good contact with Arthur, so you can hear me.
I can hear very well.
Yeah, and I can just say that your voice is a little bit broken, so if you can speak as close to the mic as possible, that would be wonderful. Yeah. Right now, I cannot hear you, so.
Is this better?
That's 100% better. Thank you so much. And I can just start congratulating for this excellent work. It's really, really impressive how you started with observational studies and then continued into a very large project, unusually large for a PhD project. I can start saying that. And if there are relatives, I can start to say that Arthur has done a really good job. And if it sometimes sounds a bit critical when we discuss for the next hour and a half, that's just the way it should be in a PhD dissertation. Can I just ask you, when I looked you up at PubMed, you have quite a few publications. So you have been in research for how long?
Maybe properly since 2012. Yes, and that would be maybe 13 years. including this
Yeah.
year.
Yeah. So how many publications have you published so far?
There are more than 70 publications.
Yeah, that's really wonderful. And can I just start with an overview how you got interested into this and when you decided to develop this into a PhD project?
So because my focus had been trying to improve, one of the challenges we had in our ICU at Mulago was that there was a very big demand for respiratory support. And I was in a national referral hospital. And at the time I started thinking about this work, we only had 6 beds, could only ventilate 6 patients at any one time. And you go to the wards wherever a patient, you need a consultant, you can't help. And I started to actually think about, my focus was, okay, what organ dysfunction should I tackle first? Because you had septic shock, you had traumatic brain injury, you had respiratory failure, you had cardiac failure. And I felt that having respiratory support would also help the other organ dysfunctions like sepsis and so on. And I decided to tackle that first. So the first thought process actually started around 2016 on how to think about going around this. But initially, very hard to get funding support, PhD scholarships, because a lot of support was going to, the more general areas, HIV, TB, malaria. So it was, getting support for anesthesia for a PhD was quite hard. But we got lucky around 2017 to be able to develop and start this work. And I think knowing that we had difficulties in admitting patients in our national referral hospital, I thought to myself, what else is happening around the rest of the country? I mean, people must be dying, and I figured maybe we can do something about it.
Yeah, thank you for that overview. I suspected it was that way, but I really commend you for having been able to pursue this PhD work. And I think you're right to concentrate on the respiratory part of intensive care or critical care. When I started, it was definitely the most common diagnosis in our ICUs in Sweden. If you looked at the diagnosis, it was always the top, acute respiratory failure. In later years, it has decreased, but I don't think the panorama of patient has changed that much. It's just that we have, as you said, divided the diagnosis more intensely into different aspects, but all of them almost every time have a component of respiratory failure. So I think it's wise to have that as a focus point. I just would like to come back to the situation you have in Uganda. You said you had 6 ICU beds, and in Uganda, 1 bed approximately per 1 million inhabitants. Do you know, I mean, this is very low compared to European standards. Do you know what our perspective is in Sweden or in Europe? What is a normal country's number of beds?
Yes, of course it varies by country, but it could be 60 to 120 beds. In some places like the United States, it's even more crazy. So got almost 200 beds, so a 1 million population.
Yeah. I think in Sweden we have 50 per 1 million, which is the lowest in Europe. And as you say, Germany and United States, they have even more. In some parts of the United States, I think it's up to 25% of the beds in the hospitals are classified as critical care beds. So it's a big difference. And can I just ask you how you, when you assess evidence from the high-income countries, how do you treat that type of evidence in your practice and in your research practice in Uganda?
Yeah, I think, of course, the first thing that hits me whenever I get evidence, especially to do with resources. So there is a steep shock because of the disparities in resources and the ability to do all the different things, and the resources will either be infrastructure, human resources, training, knowledge, and skills. A lot of the work that I do here over the years has been first develop an evidence base. So develop an evidence base. So if I do a literature review, a very quick literature review, and I say, what are the outcomes of patients say with heart failure? And you find that, patients with heart failure in high-income countries fare much better than ours. But you have to generate that evidence first. So a lot of the studies that I've done have been observation studies, helping us to find out where the problem is, how big the problem is, and then just like I've done with the doctoral work, to go all the way of how to solve it. So that's the approach I always use. What is known here, if there's nothing known here, start with what is known, and then keep developing that.
Yeah, great answer. Thank you for that. Yes, from my perspective, it's really humbling to read the literature and realize how much we probably waste in resources in the Western world or in the high income countries where we have really no problems with putting a patient in a mechanical ventilation. We take blood gases every second hour just to check the blood glucose, but then we get everything else as well. So it's a very different situation. Also in the COVID era, we had the possibility to escalate our practice and just increase the number of ventilators in every intensive care unit throughout Sweden. So it is very, very different and humbling. And I think we in the Western world should probably think about what we're doing. Okay, so I would just like to start with a definition of acute hypoxic respiratory failure, as this is a little bit of the way into this project. Can you just define that for us?
Yeah, so the definition we used for this work was because we're doing this in adults. We focused on one, the clinical presentation. Anyone presenting with less than 2 weeks of respiratory distress as defined by either shortness of breath, difficulty breathing, and then of course whether with or without a fever, and then of course with oxygen saturation of 90 or less on air. That was our broad definition, because the focus obviously was hypoxemia.
Yes, I have just a question there. How exact is that definition, do you think? Is there a big risk that you either over-classify patients or under-classify patients with that definition?
Yeah, it's something I've been thinking about, because we initially, my initial suspicion was, my initial intention was to include all comers. This would have also included patients with respiratory failure, cardiac origin, and so on. And I think that there are subgroups that we may have missed with the exclusion, and then subgroups that we may have included with the inclusion, where as soon as the patient, after 24 hours, there was a possibility that the hypoxemic aspect will resolve very quickly, even without gas. For example, this was a patient who had pulmonary edema that responded to diuretics. That would now not really classify as the kind of patient that we are looking for. Of course, we want the patients who are, the bias being that infectious diseases predominate in our setting, and those types of patients would need much longer hospitalization and much more therapy. That was the bias, I would say, for this work. And typically, some patients with cardiac pulmonary edema, once they started their therapy and diuretics, would get better, then just jump out because they would no longer have any of all the other symptoms that they had. There were patients, for example, especially ICU patients, who, especially traumatic brain injury, who were being ventilated more for given respiratory support, more for airway protection instead of the plastic definition that we wanted. That was a group that I also felt because perhaps they had any pulmonary edema and might have kind of confounded. I do not think they confounded this very much. I think because perhaps because the burden of infectious disease is really, really high. But I'm aware of the fact that some patients that really noted.
Yeah. Thank you. Excellent. And I just wonder, I couldn't read that really. Who did this assessment of the diagnosis of acute hypoxic respiratory failure? Was that some trained individuals, or was it outsourced for the clinical doctors, or was it research managers, or who was it?
Yeah, there are some resources that we don't have to do this, the kind of research that's done in the West. So, but we also, because we are looking at this from more of a capacity building perspective, the first study that we did at Mulago was easier to do because we used at that time had anesthesia residents who are now anesthesiologists, so they understood the mechanisms quite well. And obviously, it was a smaller setting to collect this data. The other three, but this taught us about the other three sites, we were able to use the funding that we got to train medical officers, but every site had an anesthesiologist who was the site investigator or site supervisor to keep, troubleshoot with any of the challenges that again, the feasibility of this work was, the goal of this work was obviously look at the feasibility of patient care, but as well as making diagnosis. So these always tended to be junior medical doctors. So in Sweden, you'd call them underläkare.
Yeah.
They're just medical education. So and then the nurses. So we train them on data collection tools and we let them do the work.
Yes, great. And you touched on this that it was easier in the first trial, which is single center, and became a little bit more elaborate in the second one, which is a multi-center. So what would the pros and cons be with a single center and a multi-center approach to research? Can you just?
Yes, I think that you can't really draw any conclusions with a single center. First of all, was the national referral for Uganda, and there was a thought that sicker patients would present, and if you saw, the high mortality of almost 77 to 85%. One would surmise that perhaps they started at another facility and then they were referred to the national referral. and saw that even perhaps if we had all the resources, that might have still been high, I don't know. So we wanted to see, and remember, because we knew the challenges that we had in a single center, in order for us to have something generalized that can be referred to from a policy and evidence-based epidemiological perspective, we needed to do the multi-center one. And you could see that it maintained the prevalence, but changed the mortality out, the outcome aspects. Something that was perhaps less shocking.
Yeah. We can come back to that. So what you describe is basically a concept where which you discuss a lot in research, that you in a single center you can have a protocol and you can be very strict and you can have control on every data point, and you know that you've actually reached all the participants and etc. And that's sometimes called something when you have a real control of your data. You get do you know what terminology I'm after here?
Somewhere.
I might be a little bit imprecise, but what I'm thinking is the validity of the material you have and the results and the conclusions you can draw.
Yes. Yes. Well. Yes. But what I want to say is that the lesson learned from that, we strengthened our data collection in the multi-centric phase by using electronic data collection forms. Yeah. And of course, we actually had study monitors who made ensure, because when we were getting approvals for that came up quite a bit. And so we tried to eliminate that bias or whatever, I think the word of the precision of the data or the certainty of the evidence.
Yeah. Yeah, that's great. So what I'm after is really that your internal validity was probably quite high in the first trial. Yeah. But that's not everything you need in research. You can have very high internal validity, but it's then the external validity might be lower. But when you introduce the multi-center setting, you may lose some control of the precision of the data and the internal validity, but your external validity increases.
And that's what we try to do.
Yeah. And as you pointed out, to get generalizable results. But in the perfect world, you would like to have both internal validity and external validity as high as possible. But as researchers in multi-center settings, we know that is difficult. Okay, so that was the definition of acute hypoxic respiratory failure. In Sweden, we rarely use the hypoxic part of that definition. We usually say acute respiratory failure. Do you know why we do that?
Well, I think that because you're probably trying to have a much wider catchment. Every respiratory failure is itself an emergency. And so it's investigated. The reason we started hypoxemia was, I guess, the lesson learned from the need for respiratory support, especially with oxygenation. We wanted to tackle one particular subgroup because our population is younger and more infectious prone. And that was the rationale for me paying down that approach.
Yeah.
I know that, yes. And of course, I think hypoxemia being a very poorly, as you have seen from a lot of the data around, when we asked the question we asked ourselves, I asked myself, is what actually kills the patient? And that's what I wanted to focus on and build that till we get to the point where you can say acute respiratory failure.
Yeah.
Yeah, the biggest challenge we have is that even the diagnosis from the rest of the land is that even just hypoxemia itself was not very sure, was not very well understood. And I had the fear of going down, that if I go down the route of acute respiratory failure, which has the four subtypes, but the most two common types being the hypoxemic part and the hypercapnic part. We also looked at the fact that our COPD burden is not as high as it is in the West, and so the dangers of being judicious about oxygen, because the patient might be CO2 dependent, would probably not be the biggest problem we need to solve in this setting.
Yes, exactly what I was after. And I just wonder, in our practice, we rely a lot on the possibility to take blood gases and assess the carbon dioxide aspect of respiratory failure. And that's often the parameter we use to act on rather than the hypoxic component. So can you you have worked in the high income environment. How would you think about that aspect of not having this possibility in a great extent of the patients?
The possibility to do blood gases.
Yeah, and assess
Yes.
Carbon dioxide levels.
Yeah, that's so philosophically. When I was thinking about this work, actually, initially when I started with one of my colleagues sitting here, we talked about because if I committed myself to acute respiratory failure, it would behoove me to make sure that I bring blood gases to rule out CO2. The few times I had CO2 ability to do blood gases, especially here, because that has happened before, we found that the reason for hypercarbia in our setting is more related to more the respiratory acidosis that's not related to COPD that we could actually manage quite well with ventilators. And then the question was, all right, you don't have ventilators, what's going to be the benefit of doing blood gases for CO2 measurement in the setting? But if we had high flow nasal cannula, which just could wash out of CO2, would have argued for that. But even further along, we just decided that it might be a pitfall or a trap when it actually comes to protocol development. Well, the two, working in a high income setting, burden of COPD is much higher. The need for CO2 measurement is a lot higher. It's older population. In Italy, for example, where 90% of the population were smokers, it made sense to have CO2 monitoring. In our population, we are only maybe 9% smoker. The average age is, the median age for the whole population is 50 years. I did see the rationale for having CO2 monitoring before we be able to monitor CO2.
Yes. Thank you so much for that. I would say that in Sweden, very rarely a patient dies of hypoxemia. There are other causes of the death. Hypoxemia is part of the scheme, but it's not the reason that the patient does not survive. I would assume that it's different in your setting.
Yeah, absolutely. I mean, the first single center study doctors, because that mortality related to hypoxemia in our setting was even much higher than any other condition that presented to blood. 85% mortality at 90 days is something we do not have in mind.
Yeah. Okay, so going from the acute hypoxic respiratory failure definition to the more severe one, ARDS, acute respiratory deficiency syndrome. you used the modified version that Elizabeth Riviello suggested.
Yes, we did.
Yeah. And what do you generally think of the RDS definition and the Berlin definition? Do you think is it a good definition or a difficult definition?
So because it's a single, like sepsis that keeps changing goalposts every time. When I thought about it, I was like, okay, what's the first? What again? I came back to the fact that in our setting, we're not able to adequately measure that. When we did the study in the ICU, we did it because we wanted to add to some validity, sense that in the ICU, patients were mechanically ventilated. They had different levels of PEEP, and therefore they had, in those that made the diagnosis, they actually had true ARDS as close to the Berlin definition, and we ruled out cardiac causes. So we came as close to the Berlin definition, still using the SF version because there are no blood gases. And that's why we chose ICU patients who are mechanically ventilated. So because even at review, that question came up and we said, yes, patients all had different manner of PEEP, and therefore made it a little more closer to the Berlin definition. The Kigali modification used lung ultrasound. And we used surrogates because not everyone had lung ultrasound in our ICU setting, but we did express and ruling out cardiac cause as well. We felt were the best surrogates for that. The ARDS definition is good for ICU settings. It doesn't help much outside the ICU, especially in our setting. But we also saw that even in our ICU setting, the diagnosis was not very well done because of the lack of blood gases. But having the modification using SF with education can help stratify by severity of hypoxemia alone, and maybe perhaps use other clinical parameters to rule out kind of modify the Berlin definition a lot further so that you're closer to what the true pathophysiology there is.
Do you, and there is, as you probably know, it was not, I don't think it was referenced in some of the papers because they were published before, but there is, as you probably know, a new global definition of ARDS.
Yes, there is a new global definition. It's some of the changes. I mean, the changes are minimal, but they still don't address the needs of places of low resource settings. We were asked to submit some, and there are footnotes to that, but we still need to be in a very relatively high resource setting to meet the global economy. Yeah.
It's interesting. It was published last year in the Blue Journal, and it's a very, even if it's supposed to be for a global definition, it's a very, the author positions are very much concentrated towards the high income countries. Just an interesting observation, I think. So the SF definition that you use, is there any relevant caveats or problems with that definition as you see it?
Yes, I think if it were down to me, I think it would be more valid if the patient was on some sort of interface that would give that would provide an FiO2 higher than room air, because you're giving some sort of I won't use the word stress, but you're giving some sort of therapy that is actually going to much further expose the sickness in the lung parenchyma. There might be very many reasons why an SF ratio of room air might be difficult because the changes after even just a little bit of oxygen can be quite significant and move a patient from moderate to nothing, So I think what we hope to do, to study further, is to have, once people are educated on the low flow oxygen therapy and what high flow, FiO2 can be, then perhaps it might be a much stronger definition. I try not to use it for ARDS per se because I try to keep it within severity hypoxemia. Yeah, of course, the other aspect is the other issues like the ROX index, how hard is the patient breathing and so on, especially room air might. That's why I would start the patient with oxygen and then get the true measure of severity hypoxemia, because those parameters change.
Yeah, I think that's extremely good observation, and that's what my thoughts were as well. And I think it's definitely possible to strengthen this definition much more, and also the aspect in the PF version. A higher fraction will definitely give a much higher value on the pressure component if the lungs are healthy, while in the SF version there is a cutoff or a threshold for how much you can increase the saturation.
Yes.
So do you think that this could have influenced the results of your work?
To an extent, yes. I think that that's the reason why we coupled sickness scores so that we pick the truly sick patients that present to us. One benefit we have in our setting is that people will not come to the hospital for nothing, and because they tend to have delayed presentations, come a little later. They come when they're quite ill, and therefore the tools that, the SF ratio that we use would actually pick out more sick patients than those who are not, mostly because I guess health-seeking behavior, as well as access to healthcare. So it costs money to come to the hospital, and you also lose money when you come to the hospital because you have almost 95% of the population is informal. So everyone is doing some hand-to-mouth kind of daily work. They miss one day of work, then they don't get it. But that's obviously a more social aspect. But when you think of globally, here when someone presents and they are ill, they tend to be really, really, really good. So we used scoring. We used score which measured other aspects of patients' health to actually categorize their illnesses as being true illness, understanding the weakness of the SF, knowing that that would be, they would pick up true hypoxemia.
Yes, and we come back to that through the last trial, the last publication in your PhD thesis later on. But I just wondered, at least in the version I have in your thesis, I guess it might have changed to what you have submitted, and maybe after review it may change even more. But do you think there is a risk that you have misclassified severity using those systems that easily give higher fractions of oxygen, like the high flow system, for instance?
So the advantage with systems that especially because they tend to provide a sealed effect, to the patient is that typically you start the protocol to start at the at the highest FiO2 and then titrate downwards. So I think it's possible. I mean, there's no perfect trial. The advantage is that these are within ranges. So if someone was less than 235, they're probably, let's say, within a standard deviation of 5 to 10, either side, because of the devices that we use. I think risk classifying, like I mentioned, and we might think more possible in the local therapies, especially if patients are not as sick as at the start. But I think in sicker patients that might be less of a problem.
Okay, thank you. Great answer. Okay, let's see. Yes, I have one a little bit general question as well. You show in some of your work that our ARDS was quite heavily underdiagnosed in the ICU setting. The diagnosis was not there, and when you measured it was higher. And just philosophically, if you research different syndromes or diseases, I guess this is a general problem that you don't. It's difficult to catch the patient you want to include in your studies. Can you just try to compare TBI, ARDS, sepsis, cardiac arrest in that aspect?
Yeah, a lot of them, first of all, rely quite heavily on diagnostic tools. And I guess again, it depends on the setting and the resources that you have in terms of catching that aspect. You already know that the underdiagnosis of the ARDS in our setting was because of that ABGs, no one wants to commit themselves to making a diagnosis. They would probably say, probably ARDS, but because they don't have that gases. Cardiac arrest is generally might be the amount of diagnostic tools that we need here. All you need is someone to collapse, and you feel for a pulse and they don't have it, and then establish for management. So that's a little bit different. Traumatic brain injuries, yes, they have a part of it. Right? The degree of severity, unfortunately, would need perhaps a CT scan or optic nerve shift ultrasound to tell you there's edema and so on. So I think with sepsis, that's also keeps changing. But as long as it's recognized organic dysfunction, it's suspected of confound infection, that's easier than diagnosing ARDS. You have 4 parameters of ARDS that you need to have to come to a diagnosis. So that's where the biggest challenge, I would say, is at the moment.
Yeah, it's definitely so. And I realize that every morning I come to the hospital. I run a sepsis trial right now and a cardiac arrest trial. All the cardiac arrests, they are captured, they're included in the trial, while the sepsis diagnosis can be disguised and no one really thought about it, and that patient is not included. So I think it's pros and cons with the different diagnoses to study in research, that it's some of them, like ARDS, like sepsis, they are more complicated to capture. Okay, just a few other general aspects. We already know about the problems with the ICU beds, the problems with mechanical ventilation and blood gases, as you mentioned. Other aspects of like critical care that sometimes is connected to the acute respiratory failure situation is whether you can calm the patient down. So I was just thinking, how much sedation was used in these patients, and could you give sedation in the out of or the outside intensive care group of patients?
Yes. It was only in the ICU patients that received sedation. So long they're trying to work on the. Okay, there's just some IT help. Yes. So no, in it again, sedation practices even in intensive care are a study has just been done for us. The first study that we did around 2015, a multi-center study that we published then, we generally used very heavy and benzodiazepines. Now that study was looking at the incidence of delirium, and it was also in a setting where access to opioids was still a problem. Now there has been improved access to opioids, and I think a lot of clinicians are going, I think, a little more heavily on opioids and less on benzos because of delirium, but perhaps as well because the practice is changing. A colleague has just done a big study looking at ventilation practices. I think there's an aspect of sedation that outside the ICU, we thought about during the COVID pandemic, thought about using small doses of midazolam or diazepam. The challenge with diazepam is that it was more sedative than midazolam and had a longer term effect. And so that we decided not to put that in the protocol because if there were any aspects of dose related side effects, we didn't want that to confound some of the aspects of the study. Generally, in this group, when we were training staff to give the non-invasive respiratory strategies, we protocolized in such a way that the patients had control over their, over the devices and got used to them rather than just slapping the devices on their faces. And that way, minimize the need for sedation. In the trial, we had almost no withdrawals from randomized patients, and that spoke to the ability of the staff to calm the patients using the method that we have used. And this method is not novel, that's per se. It's being used in high-income countries where you quietly you phase in the therapy so that the patient feels comforted, as much as including adjusting the temperature of the humidified water, the humidification as well, and then adjust it as patients acclimatize to it. Are there missed opportunities? It's possible that there might have been patients that would have benefited. But again, because of the high treatment rates, it might not have been a problem because of the training of the clinicians and the research participants.
Yes, thank you. Regarding sedation, I think sometimes we use it too much in our practice. And I think we escalate to mechanical ventilation quite often due to too much sedation that we give in some sort of. We think it's of benefit for the patient, but sometimes I think might not be. Okay, regarding COVID, was that something you have had in your plans when starting this project? I guess not. No one knew it would come. But was it a benefit for your project, or was it a disadvantage for your project to have COVID for those years as a relevant part of the acute hypoxic respiratory panorama?
Yeah, I think I can summarize this in two ways. No, we did not expect it. When we started the work, we did not expect it. But again, when it came, it presented an opportunity for us because at the time I was I was starting to work with the Ministry of Health more for critical care capacity building rather than for oxygen. And then it enabled us get a lot of goodwill for doing the work in many sites. The recruitment rate was quite high, and I think, of course, we also leveraged on the equipment we advised the ministry to procure for COVID management, and thus we were able to do some of the work that we have done. The only thing with COVID was that I felt that we missed an opportunity at that time, to study non-COVID related acute hypoxemic respiratory failure, but we pivoted very well. I think that it allowed us to understand more because the patients were sicker, and hopefully, even with the government coming in, like a lot of the co-authors work with the Ministry of Health, they started to understand the illness a lot more and can make informed decisions regarding respiratory care management now in the healthcare system. Maybe the one thing it did was just delayed, maybe I lost a year too, because everything was shut down. So the progress from the academic side, the student side was delayed. But overall, I think COVID helped us.
Yeah. I must commend you for doing the research during COVID period. Some countries shut down totally, even for the respiratory research. That's really, really great. I wonder, for the proven therapies of COVID, how much of that were part of your protocols?
No, the frugal therapies we were using. Because in all the work leading up to the trial was observational, and we said, okay, let's use the science of CPAP, but we knew we wanted to deploy the Wozniak system. The challenge we had was we couldn't acquire the Wozniak system during that COVID time. Well knowing that the Wozniak system doesn't need electricity. So there is a place for it, and that what we're trying to drive our validity was, one, a device that can be used by anybody, a device that does not need a lot of maintenance, and if necessary, a device that may be a little more advanced, like high-performance camera, but again, the ability for it to be deployed. Now, working alongside that, we knew very well that we have to make sure that oxygen was available to a minimum. So, especially because in many respects, there are more high flows, because the Wozniak device uses the flow meters of up to 30 liters per minute. So it helped us work with the ministry to actually go ahead and do, oxygen calculations for every hospital. And using and factoring in, high flow and CPAP systems towards the calculation, so that even the oxygen plant that were installed and all the resources around them, tango cylinders needed, would make sure that the frugal devices would not be a problem for patients.
Okay. How much immunomodulatory medications could you provide to the patients during this period?
So we used basically the recovery study, the dexamethasone as the immunomodulatory. The rest, for COVID, were left to tocilizumab and so on, were left to availability, because that was under the remit of the Ministry of Health.
Okay.
Mostly severe disease, yes.
Yeah. There's an interesting parallel to that just recently published from your neighbor country. Are you aware of that?
Yeah, I am. I also the editorial for it.
Yeah, I saw that.
For Africa.
So, what do you think about that trial?
But I mean, it's very good news. Even though the mortality difference being significant was not that great, but like I said in the editorial, perhaps combining glucocorticoids with improved oxygen management would actually bring that number even the mortality rate lower. And you know, perhaps it's one of the things I wished I would have done was do that. But perhaps maybe in the future with our colleagues from pulmonology and so on, that's something we might consider, maybe together with the Kenyans. But yes, even the dangers of hyperglycemia that are glucocorticoid mediated, they are short-lived because the therapy time was low. The 16.6% hyperglycemia in the corticoid was actually 4.4% that was that had severe adverse events. I should have written that in the editorial, but you know, I didn't want to water down some of the concerns that some people had. But it doesn't have a long-term effect on, you know, patient outcomes if you give a short course of steroids for 7 days that you can tap it out.
Yeah, that's great. Yeah, I read that. It's very well phrased, your editorial, and it's always a balance how much critical you should be and how much you should laud the authors. But it's an interesting trial, and I think this is something that we need to expand further. Okay, let's go to these observational papers you have published and that are part of the PhD thesis. You write sometimes that it's a prevalence study, sometimes you write it's an incidence study, and sometimes a cohort study. Could you discuss a little bit about the differences between these definitions?
Yeah, some of those in the thesis are a typo. When we set out to do the work, we wanted to the first study, the period prevalence study. We wanted to follow each up with the second study being a cohort that would perhaps do a lot more work with get the incidence of acute hypoxemic respiratory failure. We were only able to get in-hospital incidents, but it was a mix of in-hospital incidents, which I will correct because I can understand the feeling, and then prevalence, because those were all comers that presented the condition to the hospital. We have two patients. We have those that presented and developed acute hypoxemic respiratory failure in hospital, and then those who presented we did. Those are the ones that we decided to focus on, being that we didn't have the incidents in the past study. So it is a much smaller sum for incidents. That was the one that was also the cohort. So we focused more on the bigger group that had the prevalence. I'm sorry for that check. I'll improve it correctly.
Yeah, but it was an excellent clarification of that. Yeah, it's always a little bit confusing how researchers use these different, and there is no exact strict definition either. So cohort is sometimes used various ways. Okay, if we go for this first study, we have discussed for an hour or so, and people might be really afraid that I say it's the first study, and then we have 5 to go, so it will take many hours. But I'll know about the time aspects. Just reassure you. But I'm a little bit curious about the consort flow chart you have there, and the exclusion of patients. You had all the acute hypoxic respiratory failure patients admitted to the emergency department, but then you excluded patients with a poor prognosis and those who were unconscious. And it was quite a very few that were included in the study compared to those that were excluded. Do you think that is that a problem, or is that really the way it is? Could the numbers you provided, the 4% prevalence, could that be?
Yeah, it's something we thought about. I think the biggest issue was that this is a medical emergency department, and we did a period prevalence study. And of course, because we needed consent, and then the patients needed to meet that criteria. Many came with other conditions, of course, from kidney disease and so on, gastroenteritis and so on. And then those, when you look at the 357 that met the criteria and all the way down to those that we analyzed, it was a bit there was a matter of concern, but what gave us comfort was that when we did the nationwide study, the result was replicated. So, and I think going back to what you asked about whether we might have missed some patients because the criteria was tight or was the way we made it, that's also possible. But that is why we actually wanted to do the in-hospital incidents as well in the follow-up study.
Yes. And I have one question. Since the question was to whether define the prevalence, what are the study objects, the participants in this study?
Oh,
I'm not really sure that I agree with your definition.
These are all adults. For all the work was you have to be 18 or older. In this setting, most of the big hospitals split emergency departments. But for this particular setting, there's a separate pediatric, surgical, obstetrics at this time. So we're getting adults 18 or above.
Yeah, because I would argue that acute respiratory failure is not maybe the inclusion criteria here. It's rather an outcome also compared to the larger population that were admitted to the hospital. So that's just a definition question, but since one of the main outcomes are the prevalence, it might be that the whole group is the studied population rather than being an excluded part. Do you agree?
In this period, this would be a very high number. You can frame it that way. The only thing that if I said acute respiratory failure, acute hypoxemic respiratory failure was the population of interest that were counted out of a larger population that presented for care.
Yeah, I agree to that. It might just be different ways of looking at it. You used the Muse score, and sometimes you used a News score, and you also used another score, the UVA score, for defining who were critically ill.
Yes.
Yeah.
So the Muse score was the key. But the Muse score was the key. The other scores were scores of interest that we used as variables to test their association with mortality.
Okay, great. One interesting finding with this is that you didn't find an association between older age and mortality. Is that correct? That have I misunderstood? Yeah.
No,
So, why do you think it's like that?
I think it's because this being single center, the median age was 38, and yet in the next study, the nationwide study, the median age was 50. And that's when being older was associated with negative poor outcomes. So again, that's why we needed to do this study to see if it reflects what is going on from the generalizability aspect. But also, it's also likely that life expectancy has increased. We have a higher aging population that are predisposed to, obviously, to illness. And, in this single center study, it being peri-urban, it might be that also the population that lives around in the city is younger than the population that lives in the countryside in general.
Okay.
So
Oh, that's great. I was a little bit curious regarding in the multivariate analysis that you found the relation between HIV status and mortality, significant association to mortality, but not in the way I thought it would be.
Yeah, it's in this setting, patients by this time we had good coverage of ARVs for our HIV positive population, and it might have been that these were patients who are either getting treatment failure or were coming with HIV-related comorbidities. This particular facility generally, and I might be corrected, at this time, I think the only immunosuppressive states that patients tended to come with was HIV in terms of advanced disease. And a lot of them also had the lab comorbidities of anemia and thrombocytopenia. There might, because a lot of, let's say, cancer patients who have started on immunotherapy were being seen at the cancer institutes. But this, I must say, I might be speculating, although the aspect of treatment failure might have been a leading factor.
Okay. Yeah, it's good. I mean, that's part of our job as researchers to speculate on a high level and using the knowledge you have. So that's really good. You say in the discussion and conclusion that our studies show that AHRF was prevalent and associated with high mortality. I can agree that it was associated with high mortality, but do you think was it prevalent or was it not that prevalent?
No, no, it was. I think it was slightly more prevalent than it was similar to what has been reported in other low-income countries. But the mortality in this population is much higher than seen in. Yes.
Yeah. Great. And then we have the second, the multicenter that has a bit of the same research aim, but in a multicenter setting to get more generalizable results and external validity. But and that was, if I understand it correctly, in a different time period.
Yes, this was a couple of years later during the COVID pandemic.
During the COVID period, yeah. So that's what I wondered, why, if COVID was a problem or a benefit for your research, because I guess it's difficult to compare these time periods head to head since they're so different in the background panorama. Okay. In these two, I'm a little bit curious about the statistical analysis, because you You state that you use Poisson regression for the to identify independent risk factors for both developing a HRF and also for identifying mortality.
Yes.
And then in other parts of your work, you do not use Poisson regression. You use logistic regression. So can you describe why you chose this type of analysis in this too?
Yes. At the time I was doing this work, I was under the supervision and working closely with the statistician. Obviously, we tend to use statistics for binary outcomes. And at the time when I asked him why we were going to use Poisson regression, he said, well, we needed to have because some of the variables that we were looking for, we were bringing in variables from previous work that we had done, and then also inputting for variables that we expected to find, or variables that we kept finding to be of statistical significance. And I worked with him on that. I just agreed with him because at the time that's what seemed to make sense. And then the logistic and linear regressions were where we had much more clearer variables and confounders, both from the binary and the continuous ones.
Okay, yeah, that's a good because I think Poisson regression is really good if you want to like model how often something happens in a day or in a week, or how often do we have these things coming to our emergency departments, etc. But if when the outcome is survival or death, or discharge from ICU or not discharge from ICU, then a standard logistic regression is usually probably easier to understand. And when it comes to your sample size calculation, I really admire that you've done that in observational work, because that's not always done. But I'm a little bit curious, because sometimes you combine sample size calculation with a calculation or a definition of a time period. So it's both a sample size you want to fill up, but also time period, and that might sometimes be conflicting, I would assume.
Yeah, in the first study, because we wanted the period prevalence, we defined the period and then just recruited all comers. When we calculated sample size for the second study, we wanted a minimum, but then at some point, one of the discussions we had with the reviewers, with ECHOs, was wouldn't we risk under recruitment? Why would you put a time period to enrich the recruitment? And I guess perhaps that was one of the benefits of being in a pandemic situation, because we're trying to find what was the best balance between that enabled one to answer the minimum questions that we had from the first study, but also enrich the data enough to make some further inferences. I could clarify that in the corrections as well.
Yeah. Okay, that was a good answer. Because in a randomized trial, if you have a sample size that you want to collect, sometimes it takes 1 year, then it can go on for 6 years, and you go on until you have excuse me, the full sample size. But if you have a period it's usually that you have the period, excuse me, and collect the patients you get during that period. But the combination really is good as well, because that gives you a better view of the sample size you probably need to be able to answer your questions with some sort of precision. Just one more question regarding this second study. You stated in your sample size calculation that you estimated 35,000 adults would meet the criterion annually, and then you studied 16,700 something, but then in the calculations you use 1,500 as the group you compare the age, the study group with. Are you familiar with this?
Yes, yes. So when we categorized, we were trying to use the same format that we used on study one, and we were talking about we have patients who met unplanned admissions, and then patients who met the critical illness criteria, and that number came down. It's the same critical illness criteria that we had started last time, and that's why that number came down.
Okay. Yeah, I had to read it a few times before I really understood, but yeah, that's good. And we know that there are always differences between sample size calculations and the reality. Do you think the sample size calculations were valid, or would they sometimes you know, and you can read and suspect that the authors have reversed and started to do the sample size calculations after they have the data, which is totally wrong. But do you think the sample size calculations is relevant according to your research, or were you did you not have the data needed to do a perfect sample size calculation?
Yeah, I think because this was an interesting time, we went back and forth on what risk we would take in terms of sample size. This sample size was calculated before, but we allowed enough pragmatism to be able to get the best catchment.
Yeah.
In hindsight, philosophically, I sometimes wonder if the burden of in the absence of COVID, obviously, the burden of acute hypoxemic respiratory failure due to infectious causes would have been lower. But again, people were arguing that patients were staying away from the hospital because they were scared about contracting COVID. So that is the fence I'm sitting on. I can't, because it was a very interesting time. In other times, we would have done the classic sample size calculation and stuck with that. But in this case, we have to be a bit pragmatic so that we don't run foul of, and this is what we explained as well.
Yeah. Yeah. And how can you convince an editor or reviewers that the sample size calculation you provide in your manuscript is something that you established before you started the research?
Oh, we had the proposal, but this was part of this had been part of the PhD proposal at the time. And in our response to the reviewers, because they did ask about it, the answers that are provided here were adequate for them as well. They were actually also surprised we were able to do this work during this time.
Yeah. And there are other ways which you have done in the last part of this work by publishing.
Yeah, the protocol, yes.
Yeah. And that's, I think that's really something that you should strive to do in almost all parts of research, not only large clinical trials, but just publish them somewhere in a repository or something, and that's great. Either as a protocol or clinicaltrials.gov or something like that. Let's see. Yeah, and the next study, we've actually discussed the most interesting part of that already in our general discussion. So I think we can actually jump that one. And then we have the two last ones that work really well together. Can I ask you here, did you have plans for a randomized trial when you started this project, or was it something that you came up during the work?
No, we had plans. At the start of this work, the project was, I think, that's the benefit of having a PhD supervisor and a doctoral committee. Just as an off, when we started this work, I included genomics, microbiology, and so on. And I guess the danger of trying to do too much in a very short period of time was properly shown to me. The initial plan was to do 3 main studies, and then with the last study, actually, I just wanted to compare NIV against CPAP. I wanted to think about high flow nasocannula. And then as time went, I actually had to amend protocol to include to change now to a small clinical trial that now included high flow after my exposure to high flow in the UK and other places where I realized this might actually be of some benefit. I exchanged my thought process during this PhD, and I think that the year that I lost doing a lot of work, with WHO and with the ministry, it helped inform study 4 and study 5, because we now knew what challenges we needed to tackle and maybe yes, the evidence helped guide us what was. So yeah.
Great, thank you. Considering this next to the last publication you have in your thesis, it lines up very well with the last project, that randomized trials. I guess it was the background work to both establish the network and also establish the background variables to inform the clinical trial.
Yes, the study 2 and an element of study 3 helped us create what we call the RISE network. It is not obvious there's as developed infrastructure as what we had in high income, but we maintained a lot of the staff. Of course, we invested training, both clinical research training and also and also just the ethics of doing research. And wanted some sort of continuity so that we don't have to repeat ourselves. I must say that while we decided to do study 5, we went through multiple review processes because numbers were changing. I guess we'll get to that, but just to give you some generics, because initially we actually, from this, we just wanted to do high flow versus standard oxygen. But then, we just a little more convinced from also the positive results of CPAP that maybe we should repeat a version of the flow rally trial. And that's how we got there.
Great. Let's see. Yeah, in study 4, you did not perform a sample size calculation. Rather, you defined a convenience sample. How did you argue and discuss amongst yourself when you decided to do like that?
Yes, so with the statistician, we used the lessons we learned from study 3. And of course, by this time, we now had full-on COVID. We felt that the question was, should we use this, the results from study 3, considering that this time we're only dealing with COVID patients and COVID-related ARDS, and initially the convenience sample knew that to answer some of the key variables, because the focus was one, looking at just the respiratory support techniques, but also that the trained sites were using for COVID-related ARDS, and to be able to make inferences out of them. The challenge we had was that one, the proportion of equipment was different. So, for example, we didn't have like-for-like numbers on mechanical ventilators and NIV and high-flow cannula and standard oxygen and CPAP. There were some were fewer than others. And so at the end of the discussion, they using a little bit of the number of COVID patients we admitted in study 2, who were not that many and who were not as ill as we found in this particular, as we looked for in this particular study. We looked for a convenience sample of at least 500 patients that we'd be able to analyze, and we came close to that. It was like I said, it was a bit of a difficult time because we had no idea on the severity of how sick because of COVID ARDS. At that time, Uganda had been performing well. COVID-related ARDS was still quite rare. And we didn't see the severity coming. This decided with, I think, the Delta period where we got hit really hard. So we were actually also surprised by the recruitment, because at that time we thought that at least 500 was also being a bit ambitious.
Yeah. Okay, that's a good explanation, really good. Sometimes difficult to present such a discussion in a manuscript, so it's good to hear it. You state here that you, after the database was locked, the data underwent quality control checks. Just curious how you managed to do that.
So remember, we had this network of medical officers that we had deployed at us, and we were using ECRA format. We had, we decided there are some rules about data collection this time using papers because of all the IPC-related concerns that were there, and so we had tablets that we used to collect the data. So we had a platform that we used, and once the data was uploaded, the study monitor checked it, and if there was any missing data, some queries were made. And as you know, even also during this time, the advantage of collecting real-time data was also the fact that, we didn't have, again, because of IPC-related stuff, we didn't have last documents to refer to. So if you got a variable, you had to enter it immediately. So, and this was relayed to the study teams, and we were able to do that. So once the database was locked, it just made sure that the repository had the information needed in the time.
That's really good. I think this is sometimes things that are not as perfectly done as you have described here. Really good. Okay, and over to the last publication, the trial. I think that's really something that is you should be commended for doing such a large project in such a short time as well. And it flickered by in your presentation that it's under consideration in a quite okay journal. And I wonder, is it in any way, has it changed what I read in your thesis that is submitted compared to what you submitted to the journal?
Yes. What is in the thesis is quite comprehensive. What we submitted to the journal is just the primary outcome. So, we hope we are planning to do other manuscripts out of the same work. So the key aspects I've shared here were more or less the primary outcome aspects of Prevalence.
And has it changed anything in the primary outcome, the results from what you presented now and what's written in the thesis, or is it the same?
The main results are the same.
Yeah.
The main results, they're all the same. We've had 1 or 2 reviews where we've clarified some things to the reviewers, but in general, no, because the full bulk of all the work, maybe I put too much information in the thesis, but there's a big difference in terms of the manuscript. But we've summarized quite a bit, other than just the primary outcome aspect. That's just related some key aspects that we want to include in another manuscript instead of submitting it. Yeah.
Okay, and if you could redo this trial, would you have used the same methodology, a step-wedged cluster design, or would you have preferred another methodology in the perfect world?
It's a good question. I think if we had predicted, because we generally tend to have maybe 2 dry seasons, 2 wet seasons, this would have worked. We couldn't go around the ethical aspects. The thing that drove us to change to do a step-wedge trial was, there had been a trial that was done here and had to be stopped because of ethical concerns, and we're actually going to fall into the same situation. And so, one of the trialists here, who is part of us, advised me that on doing a step-wedge trial because it should address the ethical concerns. As to whether I'll do another, perhaps, but again, in hindsight, I would have done a like-for-like parallel randomization, knowing what I know now, so that it helps with if we had just had, one dry season or one wet season, I knew where it could be, and then adjust to the trial in a season where we get severely ill patients. As I shared with the pattern we noticed during the seasonal variation of critical illness was really, really a big difference.
Yeah, that was my thought as well. Since step-wedge design, they advise against it if there is a temporal trend in the outcome, and that might conflict the results you get out. And it looks like it could have been the season effect could have influenced the results. Could you in any way adjust for that in a sensitivity analysis?
Yes, we tried to, but I think because I'm not a step-wedge statistical analysis expert, we had to get help doing this. Because if you see in the table, the imbalance in this final table where we had 321 in the intention to treat for standard oxygen and 315 for the interventions.
Yeah.
I think there's further analysis we might have to do, but when I show the subgroup analysis that we did, we can see that in certain subgroups, you know, in this table, there's a trend towards favoring the non-respiratory therapies, and yet we didn't power for that specific. We grouped them as one intervention against against standard oxygen, and perhaps the other thing where a parallel design would have helped, especially if we knew the season where severity would come, maybe the results would have been more favorable than very. What I would like to say, I think, here is that the interventions tended to be better for, you know, patients with refractory hypoxemia or moderate hypoxemia, but not for severe hypoxemia. And that is a small group that we know will definitely benefit from mechanical ventilation.
Yeah. Okay. I mean, parallel design is, of course, always the better option, and but sometimes it's from various reasons difficult. It's incredible that the Mega Rocks trial, the trial from New Zealand with 40,000 patients with different oxygen targets, it's actually an individual patient randomization, which is probably unheard of in our setting. But could you have chosen another type of cluster randomized trials, just a standard cluster randomized trials, or a cluster crossover trial?
Yeah. So the weakness in this study is the fact that we do not have, this was a final destination patient, so we did not have, mechanical ventilation. So it's likely that if we had mechanical ventilation, for example, the results would have been different. But we couldn't, at the time, for reasons, couldn't run away from the stepwise design, and I think that might have had something. The other challenge with the clusters is because we do the clusters in a geographic manner, and seasons here tend to be interesting, maybe climate change, but it's a rainy season in Uganda. Many places get it, so the cluster effect might not have been strong if we were trying to deal with temporal patterns.
Yeah. In Sweden, it's impossible to do the cluster randomized design, since our lawyers say it's unethical to do it because you cannot contact the patients. So we cannot do cluster randomized trials in Sweden in unconscious patients, or patients that are don't have the possibility to consent. So that's interesting. But I understand this design from ethical reasons. But do you think you can use this data to redo the trial in the future, or has the train left the station for this?
I think now it's actually, now it will be easier, because the fact that it shows no difference means that we can now move from not parallel design, because now we have proof. We can show that if the reviewers, then what we do is we just tweak some of the other, because it was very, very pragmatic. So we can change some things. We can this time include crossover designs, and so on and so forth.
Yeah. Yeah, that's what I thought as well, that you could probably use this as a leverage to discuss at least the possibilities to do that different design. And I would really be intrigued if you have the power to do this. It would be extremely interesting to see the same research question handled in a different model. Yeah.
Yeah, it's money we need.
Yeah, of course. That's always the problem, but we can maybe discuss that.
Okay.
In Sweden, it's probably possible. In the United States, not so much today.
Oh.
No. Okay. So the main comparisons was standard oxygen versus intervention.
Yes.
Yeah. But then you had the individual randomization between the two interventions. That's really elegant design. Was that that comparison between CPAP and high flow? Have you provided that data in the primary publication as well, or is that?
No, because the primary outcome was control versus intervention, and that might come as we only made mention of the fact that high flow was best for refractory hypoxemia. We might be questioned on the power, but we have to share the scene.
Yeah. So if you would have redone it, would you have compared it only to one of the interventions, or would you have continued to have it as you have it in the?
Yes, I think the burden that I had from a personal perspective was that there is a place for the Bosnian CPAP system in parts of the country where electricity is a problem, and that I think was on me because my colleagues wanted to do a direct just high flow. So this was more saying, okay, if we can show this works well and we can show this doesn't work. Yeah. So what I would do, would probably do. I'll probably do some sort of adaptive design and keep until we find the right spot. It's using some Bayesian analysis. But if I was going to do another like for like, I would just go high flow versus standard.
Yeah, that's this is very beautiful, but it's also a little bit complicated. So to provide, I've realized that the most beautiful research presented and the one that has the highest impact and can change practice and is usually the one that is really, really simple in its design. So also the adaptive Bayesian methodology might also be sometimes a little bit confusing, and that you get when you have the possibilities to adapt, that might rather limit the possibility to interpret in the end. So, but we can discuss that later on if you continue with these plans. Just from a general point of view, you had quite little missing data on the primary outcome, which is incredibly good. So if you end up in a trial in the end and have a certain amount of missing data on the primary outcome or any other really important variable, what are the possibilities to make up for that?
There's statistical methods of handling this data. Mice, for example. I'm not quite sure. I mean, of course, this is after, again, depending on whether we are looking at the binary outcomes or if they are continuous. But sometimes you might want to, because adjusting. But again, the only method that I know is mice itself. But I'm not an expert at that.
No, that's difficult. We sometimes use worst case, best case scenarios that we provide the missing persons either having the worst outcome or the best outcome, and that will give at least the limits of the uncertainty that you have in the. So I think that's a very understandable method. It might be a little bit too conservative, but it's also quite good, especially if you have results that are on the vulnerable end of being statistically significant. Then you can show that if you just change these to good or poor, you would have the opposite results of the trial. So, but of course, multiple imputation is probably more powerful, but sometimes a little bit misleading, I think. Okay. And this, you state here, the calculated SF ratio was significantly lower in the intervention group compared to the control group. And this suggests that the intervention group had more severe hypoxemia at baseline. To connect back to our previous discussion, do you think that the SF ratio way of evaluating hypoxia could be misleading here, that this might not be true?
Yeah, I think that, like I said, I think that if patients are not as sick, that's where we might have some misinformation. I will not say that I know to what degree that would be. The patients in the intervention were getting, true FiO2, much more reliable FiO2, and therefore the certainty of the SF ratio was much stronger in them. So in the patients that were in the lower floors of standard oxygen, a lot of things, even the calculation of SF was, it's not perfect in terms of, it's been done in a lab, but, with patients' respiratory efforts and entrainment and all that, there are going to be variances. And that's why we give them ranges. So what we did, we just say, okay, you calculate and provide, and the question was, do we provide the highest possible range or the worst possible value? And we went for the worst possible value because we thought that pick up more true disease, more true sickness than the other. But I feel that that's one weakness, SF ratios in low flow oxygen therapy.
Yeah, because you state here that they required higher oxygen flow rates, but I rather would say that they received higher oxygen flow rates. That might be a difference.
Yes, as per protocol, that's what they did.
Yeah.
You notice they needed more. They did both, required and received.
Yeah. So it's both required and received. I agree fully. Okay. Then you state somewhere that only 3% were intubated.
Yes.
Was that similar between the groups?
No, more in the intervention group.
Yeah.
Required.
And how come? Do you think?
I think that, the centers where they received intubation had access to intubation. And I think they were lucky to get that intubation because 33% of patients needed intubation, but they didn't get it. As per the intubation criteria we are generating. I think there was some sort of, also there was some, this is just my thought process. I think there was some sort of bias towards doing more for the intervention group, especially when it became much sicker. And it might be that that generated some sort of treatment bias or intubation bias. I feel that also the study teams got better as time went along, and maybe they created also, other than early identification treatment, but they also created better relations with the ICU teams to allow, because once the patient met intubation criteria, that was documented, but also a request for intubation was sent to the ICU. But that was also left to chance whether there was availability of resources.
Great answer. I think I must say that I'm satisfied here. I have about 200 more questions, but we'll take them at another time when we meet. I will not continue after this. I think you have answered excellently to my questions. And I also had some questions about your future plans, but you put that very elegantly in the presentation. And I just would like to say that I wish you good luck. It's an impressive work, and I think there is a lot to do. I wish you more resources, of course, but I think to really establish practice also in this challenging setting is really something that is has a great value for humanity and for your community. So my sincere congratulations. So thank you.
Thank you, Professor Nielsen, and thank you, Alpha. I must say I'm very impressed with Nielsen, who was able to give us turnaround of 1 month. Very, very an example. We are really grateful for your kindness and promptness. We are really very grateful. If it takes between 3 and 6 months to read a PhD thesis and really give it, but we are really very grateful that it took time. After he did it, because we had to finish. If she goes through, he's going to graduate in January next year, hopefully. Ladies and gentlemen, I invite you to take a cup of tea now. Slowly, maybe a cup of tea and some snacks. And as we wait for the other examinations, I will start with Professor Ochama. You have, this is the PhD defense, you have the whole day. You're welcome, sir.
Thank you very much. Yeah, I think again, thank you for one. I think I've done a great work. Of course, I am the odd man out. I'm not an intervention. Not really. And probably general. But anyhow, I went through what I can say. The book was a good read. Thank you very much for the good work. Moreover, some of this work was done during that very difficult time. Full this kind of work wasn't easy. Most of the comments, and no, I think you have had quite a bit of very good discussion with and the opponent of it. So we don't even want to complain so many things, but some comments will come through. Mainly, for example, in the write-up, I read most of it. I think I read the only talk I can see. And I thought in the write-up, the abstract part is a little bit deeper. Because when I was reading it, I thought it was like I was one side that was done. It doesn't even complain about the kind of work that it is. So it's really work that is done. But also some of the comments which have come out of this time were actually already moved on during the presentation. So I don't want to go through that. Then when I started reading, I was coming from out. I was wondering what is Berlin, what we call it Berlin finisher. What it was. Because I wondered what it was. And because in a way there was being used to justify. I was saying, so what was it all about? And those components in the Berlin. Why not to handle those? This, why were you not doing that? What were the complaints? What was lacking that? And why was it modified in Rwanda, for example? So I think maybe you just need to talk more about it. so that the person who is not in this particular case can understand that one. And then you had the hypothesis for what you say that you had, and I thought some of them probably do not require hypothesis like this one. Because like the opponents say, you know, the prevalence study, the incidence study, and then for research question about which was really talking about the one that if you had some kind of effect size that you anticipated, but again, it was you know, like so maybe it didn't matter so much. The objective, some of them, the way they were written, especially one and three, I thought they would have made tighter, for example, when you say, of course, it was corrected when I listened to examining, estimating prevalence. Identifying some of the other things that we do. The conceptual framework, but it wasn't very comprehensive. Maybe we should make it more comprehensive in the final book, so that you can define all those things that you actually put them in. You know, this is study number one. So on the conceptual framework. It makes it easier for the person to tell what is what you actually did to follow what was there. In the study one, there was this 90-day outcome. I wondered how you measure the 90-day outcome. I didn't find it here in the book. I could have missed something there. And then finally, if you were to walk to Jane Ruther Jane today, what do you want to tell her?
I might respond somebody.
One thing that you want to say, Honorable Minister, this is what you need to do. So maybe I will stop there.
Thank you, bro.
Let me. So there, yes. Thank you, Prof. Chama. I would, for some of the aspects that I need to improve in the book, I will do that. Just for objective 2, we actually calculated sample size, but it was very difficult separate calculation because we were dealing with the virgin territory in terms of class randomized stepwise trial doing things for especially for medical devices. We had based our sample size for the first study, but which was one weakness because you have to go for the worst case scenario to give you an effect size that can be sample. So I will clarify that the reason why we did that. Yes, the conceptual framework. I'll make it more comprehensive. The challenge when I had making it was such a big ecosystem, that you could include, infrastructure resources such as generators and so on, things that we have identified as all the other contributors to why we have challenges with oxygen therapy in the country. Yes, the 90-day outcome, we made phone calls with all the participants. And we're just asking if they are alive or not. And that is how we got that. And was it easy? No, we had to. Yeah, this is a learning curve because I think for some, you called some numbers the next of case. The phones either had been stolen or they had actually borrowed them for the time of admission. But they were very interesting telephone practices at the time. And so We only got to 85%, but we missed quite a few points. So 85% was minimum. All right. What do I tell the minister?
Yes. Tell us now.
Thank you very much, Mr. Chairman. Yeah,
Yes. Yeah, first of all, I would like to congratulate Kwizera on a very exhaustive piece of work. It's over about a decade. This work was both in the COVID era, during the COVID era, and after COVID. So it seems to be a full spectrum. Now, this certainly reflects your fortitude and resilience, so I congratulate you on that. Now, looking at COVID-19 related ARDS and what other literature called classic ARDS, how do you think this one influences your work? We do know, like in situations of COVID, there are differences. The issue of steroids has always been contentious, but somehow in COVID was the mainstay. But are we talking about the same type of ARDS? These papers. Somewhere you mentioned the hyperinflammatory phenotypes. Are you able to highlight any of these? Dark. And other literature talk about rapidly improving ARDS, persistent ARDS. I will just, many of the issues were touched regarding the various studies, so I'll just highlight a few. There were a few issues on study methods, but maybe you'll tell us how you obtain deferred informed consent in difficult population. And somewhere you did mention this was a minimal risk study. I would like you to convince me that it was true. And also, you mentioned that comprehensive risk assessment benefit, the chief of ethics has just stepped out. So, in this situation. But in study one, you included participants with a mu score greater than 4. I think excluded those with a poor prognosis. What did you define as patient poor prognosis? Because I thought those people had a mu greater than 4. What is the reason of excluding it was? There are a few minor issues, like in one paper, I was wondering what grading you use for the adverse effects, the standard gradings, the STD dates, but I saw in one paper, paper 1, anemia was defined as hemoglobin less than 8. In another paper, we defined as hemoglobin less than 10. it leads to standardize measurement of some of the side effects, so that you may know whether a mild degree or moderate or severe degree of anemia can impact outcome. On page 30, I think that was the baseline characteristics in study 1. Diabetes was conspicuously absent, but in the subsequent papers, indeed, you did measure blood glucose. In emergency departments, diabetes is a common presentation, patient with sepsis and other conditions. And in literature, we do know blood sugar prognostically important, whether it was an omission or not. And the opponent did highlight the issue of the association of HIV. But it's in another way, because in your literature, it showed that HIV was associated with a reduced mortality in that population. It was a little bit strange. Don't know whether it is there's an explanation for that. And how many of the HIV patients were antiretroviral therapy? In study 2, in the eligibility, I didn't find whether you used imaging study or not as part of your inclusion criteria. Maybe you will clarify on that, whether imaging was done. And if it wasn't, then probably one may, I don't know whether it matters or not, that included patients with chronic exacerbation of chronic lung diseases or cardiac disease. In the study on the utility of the modified Berlin definition, I think that discussion has gone on, but questionable whether this modified definition, much as it's useful for our setting, really good as the gold standard. We know our limitations, that we're not able to do the ABGs and so on. But so at least I think we need to acknowledge it as a limitation. But we're not able to. I know it's still validated in other settings, but we'd like to know how to perform it in our situation. Opponent have mentioned the mix-up incidence and prevalence. If we are talking about incidence, then the RDS is at the baseline need to be removed from the population. So I think you'll iron that right now. Notably, patients in the ICU, as we all know, most are trauma-related patients. Of those who developed ARDS, I'm just curious to know what the trigger was, whether they were related to trauma, but this hospital acquired pneumonia, they acquired pneumonia, they had this group. So, yeah, and clearly for those who probably don't know, patients that we described in study 1 and 2, not likely the ones who end up in ICU. I think the priority goes to trauma patients. But probably that's why the mortality was 80%, in the initial study. The last study really not much to add, but it's a randomized study. The baseline characteristics in some parameters were a little bit different, particularly BMI and blood glucose. And there is literature showing that metabolic syndrome is associated with persistent forms of ARDS. Would that concern you in your analysis? And lastly, the issue of winning in these trials. Were they win using a standardized protocol? Because from what we see, winning is as important as supporting this people respiration. So if the winning is not done appropriately, it may actually be associated with increased mortality. Could that be the reason why the CPAP patients had a poorer outcome compared to their other things? Otherwise, I think I enjoyed reading it. It was really very broad piece of work, which lays foundation for subsequent works. And I think in your area of experts, I really congratulate you on reading on that. I'm sure it sets precedent for other similar studies.
Thank you, bro. Sandra, please.
Yes, at the time I was writing up, thank you for the comments. At the time I was writing up, COVID had just emerged, and we were still trying to understand. They are a different phenotype of ARDS, that's for sure. The challenge with the classic ARDS has two types, the hyperinflammatory and the other. Whilst it was very difficult to kind of level what COVID was. What we knew is that it had, over time, it had developed a characteristic phenotype. One, it was easy to ventilate in general, very difficult to oxygenate. And of course, that's the time we had the hypothesis of the clots in the lungs, vis-a-vis the classic ARDS where the patient's lungs just became very hard to ventilate and oxygenate at the same time, through the fibrobreviative and other places where it just became like bricks. The advantage between the classic ARDS, the advantage because we bring in the steroid aspect. COVID ARDS, we saw a big reduction in mortality with steroids. And in classic ARDS, there had been some sort of equipoise with regards to the effects of steroids with that subpopulation. Now we have a group in the trial that was published in Kenya by the Kenyans in New England, where they showed that steroids are beneficial. The thing that we need to establish, though, and I'm sort of agreeing with you, is that the subgroup of hypoxemic patients that Sonia, the Kenyan trial, there was no difference. So what happened is, in terms of outcome in the subgroup, because there's 200 in one arm, 200 in the other, those who got 40, those who did not get, the mortality difference was not there. And it wasn't even trending towards there. So the question then becomes perhaps maybe severity, because it was also a pragmatic trial. I think if we did a larger trial of that nature in hypoxemic patients with pump infection, we might see something that's more encouraging. But for now, the SONIA trial, we want just say glucocorticoids in community-acquired pneumonia. So it was published on the 29th. So, and maybe that points to a benefit for improving outcomes in trust areas. Some papers have been done on that, but a lot of, like with every study, the criticisms can sometimes water down the effect. And so clinicians' practices with regards to steroids focuses more on the septic shock side of things rather than classic, whether it's pulmonary or extrapulmonary. Then about the deferred consent, one of the challenges we had during trial, during COVID itself, for the last two studies, we asked for deferred consent. One, of course, getting into the COVID treatment units to get consent. We already agreed that we're not using paper. And so we asked, because we're only going to look at patient data, not participating in treatment, we thought we convinced the team that was going to do numbers. But also because in the other aspect was that the database being created by the individual health COVID task force for that. So maybe we took advantage of the situation, but for the clinical trial, the deferred consent was on a case-by-case basis because we still got consent in our way. For the COVID study, we even then, we still called patients up just to make sure documents. The minimum risk was the fact that we were not interfering in anything just their care. We thought that, and especially those who are in COVID units, once you've had severe COVID-related ARDS, you won't get steroids, as well as if there was another ongoing trial, you get the benefit of that. And of course, oxygen therapy. None of which we were involved in because it was some observations. The ones for the typos, I will address them. The aspect of, I really have to go back because we thought that, because if HIV mortality was protected, that meant that patients would get very good care. If it was, but I really have to go back to that now. I'm just going to say that's a lapse. But I thought HIV mortality was associated with high mortality and because they were very sick. But I need to get back to that and email through that. In study 2, we for this we let the clinicians make the decision because most of the regional hospitals have physicians. So and we also I hate to say this on a public forum, but many are not check the scales for one reason. Either they had no film or machine was being installed or something. So the clinicians used clinical to say that this was pneumonia or to rule out the other illnesses. In the one of poor prognosis, the first one, we again relied on the admitting physician and we asked them, do you expect, because we wanted to get enough data for at least 24 hours. And most times, the patients were in extremis and the clinician would say, this one is not likely to survive, and we worked with that. Again, one of the aspects of clinical research. Yes, I already discussed the limitations of the SF regarding modification. I personally think that it's better for the more sicker patients who are on higher. It's more accurate in patients who are on higher levels of drug because they accurately predict better. Even from the ARDS study, we see that the more patient was getting, the more likely there was a true effect of illness. And I agree with you on that. If someone is on 2 liters per minute and uses SF, the range, you're within the range of standard deviation that you can't put your arm and say that we did a blood gas this would match. So that's a limitation, which I agree with. The issue of incidence and prevalence, I addressed that with the opponent. Yes, ARDS has both pulmonary and extrapulmonary origins. And the extrapulmonary one of them is trauma. So it would be interesting if we went back to the data and saw if there was more trauma-related diaries, because like I said, surprisingly more surgical patients, either post-operative, traumatic brain injury, trauma patients were highest, I think 27% that ICU. As more ICU, I think this is also something we need to speak about in terms of policy. But the bias of admitting traumatic brain injury patients, trauma patients, I guess is best more on the urgency of the situation. A bleeding patient will always get more, someone who is unconscious, with broken arm will always get more attention than a patient who walks in and saying, I have shortness of breath, but they can sit somewhere and so on. And perhaps even, I think it's more of a social perspective thing. This also tells us that we need to do more diagnosis of severe hypoxemia in our population. That's a very interesting question. We had quite a number of baseline differences in the clinical trial, and I think it is also because there's already that discrepancy that patients in the intervention arm are sicker. So the metabolic syndrome effect might have also predominated on that. I think we can analyze that can be a paper as well, because it's a good sample size. As for winning in the clinical trial, yes, we did win in the protocolized pattern. So as much as that research, we had two areas of data. One survival at day 7, and then of course 28 days. But in the protocol was that if you still needed, whether it is CPAP or high flow, at day 7, we clocked you out as alive, but we kept you on therapy. So there's a subgroup of day 7 that we shall share later, but our primary outcome was all mortality at 20 days. So the challenge that we had was that because this was a pragmatic trial, any patients tended to get everything in the first 4, 5, 6 days, but the longer they stayed in the hospital, which is unlike what we do in the ICU. Patients in ICU tend to length of stay is about 4 to 6, 7 days on average in non-trauma patients. Patients who still needed care for whatever reason, whether it was antibiotics and so on. We only provided antibiotics and everything for the first 7 days. Then after that, we stopped because that was the point. But for oxygen therapy, we maintained until either they died or recovered. The others are this. Thank you very much.
Thank you very much. And we've come to almost the end. I will entertain the public. 1 or 2 questions. Colleagues, any questions for Arthur? I see hand line. No?
We are content.
Thank you very much. So we have come to the end of the open session. The examination panel will remain here, and the external examiner is going to remain with us. IT, I don't know how I'm going to mute the online so they don't hear the closing. The candidate will also go out. Thank you very much. Thank you very much. So the examination panel is going to decide whether after benefits the PhD or not. And after about 5 minutes, we'll call you back and give you a time. Thank you very much. The guys online, mute. Yes, we did Dr. Irene and Professor Irene and Dr. Paul Katokolo. We are part of the examination panel.
Yes, Chair.
Okay, how are you, Irene?
Yeah. Hi, Prof. How are you? I'm fine.
Okay, thank you. So we are going to get to the internal discussion, and then we give you an opportunity to make some comments.
Okay. Are we going to make our comments now, or you'll invite us later?
We invite you. Can you close the door? So I think we are now. Dr. Katongole, are you still online?
Yes, Chair, I'm online.
Excellent, excellent. So I think the panel is fully constituted. We have the examiner. Oh, the IT guys are still struggling to know how to mute people.
We need to Katongole and the
too. So doing a breakout session then?
Yes. Getting for their name, so.
Yeah.
Yeah, very neat. Except for Katongo.
It's on. That's very good.
How will the name be used?
What he's actually there.
Music class.
I am here, Dean.
Yeah, we're inviting you.
We just wanted to see how you named yourself.
So we have Dr. Andia and Dr. Katongo.
Yes.
Another?
Only opponent.
The opening has to be there.
What's the
The class is online. Very good.
Even me, I don't take it.
Yeah.
Okay, excellent. Just confirm that Irene and Paul can hear us.
Yes, Chair, we can hear you.
Yes, we can.
Can you hear us, Dr. Irene?
Yes, please. I can hear you.
Please. And then we will give an opportunity to the one or two questions to there is a piece of paper from the graduate school. We have to grade the candidate and decide whether it benefits from the PhD. So, Dr. Andrea, would you like to say something about the work? How did you find the work?
Thank you, Chair. Found his Dr. Arthur did a great job in he's very knowledgeable about his work.
Yes.
He presented very well, clearly, slowly to accommodate even those who are not familiar with the work. He had a very good interaction with our opponent.
Yes.
Yeah, and it shows that he did the work, or he was part of all this that is happening. I know that from the internal examiners, he might have had flaws in the book and here, but I think he did. He held on very well. So I think he did very well.
Thank you very much, Irene. Paul, are you able to hear us now?
Paul dropped off, unfortunately.
Oh, unfortunately. Okay. So, colleagues, what we are going to do now is for the candidate, we have a guide from the graduate school. The external supervisor, no, the external examiner, right? And opponent will not participate in the scoring of the candidate because you already have a score with us. It's only the internal examiners and the examination panel that are going to give a score. So I have just very few questions from the graduate school. They want us to assess the candidate's knowledge of the subject according to the Bible book. Do we think really the candidate is good at the subject? And we will give a simple score out of 10. How many would we really give him in terms of knowledge of the subject that he did research on? Professor Olivia, how do you rate the candidate's knowledge of the subject?
Give him
Dr. Andia, what do you think? Knowledge of the subject?
Yes, very good. I'd give him 8.2 out of 10.
8.2. Wow, okay. Professor Chama already gave his grading. He gave a 7 out of 10. And when I take an average, I find it's about 8 out of 10. Is that a correct assessment of knowledge?
I think so, yes.
How about his presentation skills from his slides and the way he really, I really thought of how he did it very easy for even the lay person to understand. So what would you score him in terms of presentation skills?
Presentation skills, I would score him an 8. I think why I didn't go higher than 8 is because I did not feel the translation beats coming through from the work very well. But I'll do an 8.
Okay, Professor Rodrian?
8.5.
8.5. Unfortunately, I can't score. Where is it? Oh, the ball is still not on. Okay, so do we do 8.5, Irene? Would that be fair?
Very, that's fine.
Okay, excellent.
Good.
8.5 out of 10. Now, Irene, I know you didn't read the thesis. For some reason, it was an error that we didn't send it. I might be just smiling because he knows it. But Professor, already you read the thesis. What did you think? Like, Professor, what do you think about the quality of the state of the book itself?
Normally, it keeps on improving as you finalize.
Yeah.
So then a few issues of formatting, grammatical issues. Some of the background they say, like as Professor Chama said, the abstract was as if you had one study, but it is broader than that.
Yeah.
I think he needs to address that. And probably but yeah, I'll give him a 7.5.
Okay. I think we are gonna go with that because Professor Chama, you are welcome back.
Thank you.
Yeah,
Thank you.
we are now scoring the candidate, and we have reached the point where we are looking at the quality of the thesis. According to you who read the book, we are scoring out of 10. How was the quality of the thesis? Professor Rodney already pointed out that you mentioned that the abstract was lacking. It didn't cover the whole book. So what other aspects do you think we're actually lacking? Or what do you think were in the thesis itself? We are scoring out of 10.
Yeah, so I think there are certain things which were not very clear, but certainly it passes. I would give him 6.8.
6.8.
Yes.
Okay, so when I get 6.8 and 7.5, I will take an average of 7. That's agreeable, yeah.
That's okay. That's fine.
Very good. 7 out of 10. And lastly, how did you respond to the questions? Especially the external examiner and you, the internal examiners. How do you think, how confident was he and how exhaustive was he in regard to answering the questions from the panel? Professor Chama, what do you think?
Yeah, yeah. I think he was confident. That is the most important thing. He was confident, and of course, this is a defense. Sometimes you may not answer the questions adequately, but the confidence is the most important thing. I think he was good, especially for the
work. If I get you well, he owned the work, right?
Exactly, exactly. He did well. Yeah, thanks.
Professor,
Yeah, I agree.
you agree. So what would you give him out of 10? Professor Chang?
I would give him 7 for this.
Okay. So Adrian?
7.5.
7.5. Dr. Professor Andia, you listened to the presentation.
Yes.
But you how he responded to the questions and stuff. So what would you score him that aspect?
He did well. He was confident, definitely. Of course, as Professor Chama says, he was not fully bringing through some, I think, aspects that the opponent wanted him to bring, but he did. He tried his best, really best. So I would give him 7.88. I don't know. I thought it was good anyway.
Okay, so when I add the 3 marks, I get an average of 7.5. Is that a fair assessment?
Yes.
7.5.
That's okay. That's okay.
That's okay. Now, what remains is, should we pass him or fail him from the thesis, from his interaction with the external examiner, from the interaction with the internal examiners? Overall, there are only 2 options, either pass or fail. What do you think?
I think he passes for sure.
Oh, Irene, is that your opinion?
Yes, definitely he passed it.
Okay,
Yeah.
very good. And so we are going to make another one vote. Should he submit the thesis the way it is right now, or does he have to make some minor corrections, or are they major corrections?
Certainly, there are minor corrections.
Yeah, minor corrections.
Yeah.
And who is going to volunteer oversee the corrections? We need one of the internal examiners to volunteer to oversee the corrections. And this gives me Professor Rodria or Professor Chama. One of you has volunteered. Who has some
I think for this kind of work, I would kindly request Professor Worodria to review those things because of the nature of the study. Yeah.
Professor Rodria, what do you think? He's in agreement with Professor Chama, and he's going to volunteer. That's Professor Rodria. He's going to volunteer to oversee the corrections. And are there any specific areas that you really think the candidate must address? Very specific ones. We talked of the abstract. Are there any other issues that you really think the candidate must? 1 or 2 or 3? The typos, the words, no? Should he delete one of the studies? Should he go anything that you really think is crucial for the thesis to go through? Irene?
I think in addition to everything else is just the translation into clinical practice for generally on the broader aspect of healthcare in our setting for policy change. Those I didn't feel like, fine, you've gotten all this, but then what didn't come out well for us to really appreciate his work. That would be for me mine.
Thank you, Professor Chama.
I agree with Dr. Andia. Professor Andia, I think, has got it right. You remember the question I asked? What do you want to tell the minister from the work?
Yes.
If there's one thing that you want to tell the minister, what do you want to tell? I think that is these are minor things which I think he can look at and he can correct them.
Okay, so Professor Olorian.
Yeah, I think all that, but it needs to contextualize this work very well. Because these are studies in about 3 different, we're looking at 3 different aspects. So I think in the background, methods, I think, should be sufficient for somebody who doesn't know the study site. They will understand what exactly was done, all its limitations.
Thank you. So I will give an opportunity to the one of the supervisors who is with us here, Gini Katete. What do you have to say about the candidate's work?
The candidate, first of all, I thank you, Chair, and examiners to take this through. The candidate's work has been good. And I'm happy to see that he has concluded the journey. He has had outputs all along, like we've seen here, but to repurpose those into a thesis has been a and the how tortuous it has been. But finally, it has come through. But I really agree. The thesis is good. There are those dots to connect, like pointed out by the examiner. Generally, can do those, and he advances. It's really long overdue given.
I agree. Again, and I really have a chair. I want to ask you this tough question. When we know Arthur as a brilliant guy,
Yeah.
Why did it take him 10 years to complete it? What happened?
Actually, I asked the same to the funders, to some people who are close to, but one person who knew him well said, that's typical Arthur. For me, I got to sense that
Interesting.
okay, he maybe got some issues down this path. Combined that he was sick, but he said, that's typically Arthur. Someone who knew him from undergraduate. That's very smart, very good at starting, but execute, implementing, and
Yes.
it's a problem that
Last year they didn't task me too for last year around the June. I managed to get him this year in February, sitting down. It took me 8 months to get him to sit down and say, please, we want this PhD. Otherwise, he's a very brilliant guy. Professor Nelson, if you are still online, we are really very grateful. We have come to the conclusion of this defense and assessment. I can't thank you more. We are really very happy for your assistance, especially turnaround time was very impressive. So if I really get this well, Dr. Arthur has been given a PhD, and his average score is around 8 out of 10. And we are now going to call him back and the other members of the public and read the verdict. And I believe the verdict is just passed, right? Okay, cool. So can we have the Arthur and his group back, please?
So I can first.
Yeah, please. Let's go back online. Yeah. Yes. Congratulations. And I once again really I want to thank the external examiner for being able to take this in this time. It's very rare, very like sometimes takes a whole year. So we really thank Nicholas Wilson. If you are still online, thank you very much. And we hope Arthur can establish maybe a collaboration with you. I see that I intend to see this, right? I almost beat my tongue. So I hope you really connect with that gentleman and you keep your work flowing. Otherwise, we wish you the best. Where is the cake?
maybe you can take a picture.
Okay, fine. Yeah. So,
I'm done. Thank you, Chair, for this. And maybe usually there are few remarks. I can give remarks of supervisor. Maybe the examiners, but if time allows, but Arthur can give the final remark, get out of this and introduce people. But Arthur, I want to thank you for really, let me say it the African way, for being a man and standing up to your word and conclude what you finished. It has been tough, but I'm happy. I remember when we were in Accra, that's where this conversation started with the venue. But I'm the happiest to see it has been concluded. Thank you very much. And please take it on from there. I think that's just the beginning of the journey. And if you need any other support, administratively, I still have a few years. Still free to reach out. Okay, over to you.
Please say something.
So everybody here online, I want to thank God. This day has come, has happened. I want to thank everybody who has supported me in this journey, from my supervisors, some of whom are here, to my doctoral committee members. As I've mentioned before, that I have friends who have poked me to try and encourage me to get this over the line. I want to thank the college, the School of Biomedical Sciences, support, the IT team that are constantly disturbing me. I mean, at the end of the day, I'm a bit lost for words. I told the guys when we were waiting, no more books, and everyone laughed at me. But I guess this means that there's more to look forward to. I want to use this as a pedestal to my colleagues in my specialty to pursue a PhD. I will definitely thanks Prof. Nielsen. You have been very kind, and you made this easy for me in many respects. You perhaps sensed my nervousness, or maybe it is a Swedish thing, but next time I meet you, it will be physical, and we shall toast to this. And as to further collaborations, I think my department would be very interested in getting quite a bit of work with you. Thank you very much for everything.
I can just say thank you so much for inviting me. I'm deeply honored. It's been a great experience, and congratulations for your PhD exam. Thank you from Sweden.
Great, thank you. So we are going to have
For a moment, and maybe the registrar can tell you the amount of time out if you want to be included in the graduation list to submit a revised version.
Professor William Orustra is going to be a guy to make sure that we are making correct what the panel has said.
Thank you very much.
Maybe, Professor Nielsen, you can stay on just where as you've been so that we take a picture with you. There's no flash, but it just looks like I don't think it's available.
Okay.
Thank you. Congratulations. For the correction, this.
Oh, bye-bye, bro. Thank you very much.
Thank you, Professor Simon.
Professor